you. Chat. Welcome, everyone. How's everybody doing today? We doing good, chat? Let me see. Where am I? What am I doing? What am I doing? What am I doing, chat? What's going on? Okay. So, no, we're not gonna do Kam Sutra. We're not gonna do, we'll do the disclaimer. We're gonna do like actual like sex ed. So let me just go through announcements and stuff first, okay? And then some of y'all may be disappointed. We're gonna do something a little bit different today. So let's start with disclaimers. So very important today. So just a reminder that everything we discuss today on stream is intended to be for educational purposes only, and nothing is intended to be taken as medical advice. If y'all have a medical concern, please go see a licensed professional and seek their individual advice. And this is doubly important today because what I'm going to do today is give you guys essentially like my sex ed talk. This is it's something that I talk about with patients a lot. So I essentially have like a spiel that when someone comes to my office and has concerns or is curious about sexual education, like these are the things that I'll explain to them. For those of y'all, so like it'll be like, these tend to be patients that are like teenagers or young adults who may not have like ever had someone sit down and talk to them about sex and like what's normal, what's not normal, what's healthy, what's unhealthy, like things to watch out for, things to be careful about. So it's not going to be, I know we're doing this on Twitch, and I know that oftentimes people will meme about stuff. There are going to be a couple of jokes, right? Because that's just how I teach. But like, I just want to emphasize that really the goal of today's lecture is to just educate people. And I strongly, strongly encourage y'all to go actually see a licensed professional if anything that we discuss today seems to resonate with you. And it's not going to be like, like this is how you have sex. It's not like a how-to guide for sexual intercourse. What we're going to be talking about today is really more medical in nature. It's like helping people understand like what's normal, what's not normal, what should y'all be watching out for. It's kind of like, this is what I'd say, so like sometimes parents will ask their kids this question. So I'll give you guys an example of why I give this talk. Okay. So parents will ask kids their question, are you having sex? And the kid will, like, if they have a good relationship, the kid will say yes. And then the parent will be like, are you being safe? And then the kid will be like, yes. And then that's the end of the discussion, right? It's like there's never, like the parent doesn't want to talk about it. The kid doesn't want to talk about it. It's super awkward. And it's like, what is the kid going to say in that situation? No. Like, even if they know they're not being safe, they're probably not going to say that to begin with. And secondly, like they may not have the same idea of like what safe is, right? So we're going to talk about like what safe is, like what are the components of safe. So another reason that we're going to be talking about this today is because, as we've not recently discovered, but as we've known for a while, our content, people watch this stream from 65 countries or 70 countries. And a lot of these places don't have, very robust systems of sexual education. So we're going to try to, teach the basics of like sexual health today. And so I, by all means have a good time, because I think that like education shouldn't necessarily be like no laughing aloud, but at the same time, like, let's remember that the reason we're here is not to like penis, like that's not what we're here for, right? We're here to actually, or at least that's not why I'm here. What the reason I'm here is because it's been my observation that like a lot of times these these conversations are actually really important, and we don't have them enough. You guys can clip that. That's fine. It's going to be the first of many. Like, don't sweat it, dude. Okay, so like let's just try to be respectful of the topic at hand. Do we want to laugh? Like, absolutely. Am I going to make jokes? Like, hopefully, right? That's just how I teach, and like I think that's important. And at the same time, let's try to like make sure that things, first of all, don't get too far. And let's remember that the goal that we're really here is to like try to learn something so that we can live like happier, healthier lives. Okay. So a couple of quick announcements. We're launching parent coaching in one day. So we still have some spots available. So we only have, 100 spots in parent coaching total. And so if you guys are interested, you can sign up there. Tomorrow we're going to have a special stream at 2 p.m. Central Time. And it's going to be a little bit more focused on TikTok. So as I understand, they want me to react to TikTok. So I'm going to just watch some TikTok and react to it, I suppose. Okay. What is parent coaching? Great question. So it's our belief or our experience that being a successful parent is like harder than it used to be. And that as technology has grown, as we get like dopaminergic stuff into our brains as like kids and young adults, as a parent, like you have to become a little bit more sophisticated in your communication in ways that like a generation ago, you really didn't need to be. And so what our parent coaching program tries to do is help parents build healthier communication habits with their kids, to be able to build an alliance with your kid, and to learn how to set healthy boundaries. Does that mean sometimes that we try to help parents reduce the amount of time you play video games? Yes. But we try to help them do it in a helpful and, like healthy way. So that's what our parent program is about. It's about helping parents sort of like learn how to communicate better with their kids, teaching parents that video game addiction can sometimes be a symptom, or technology use can be a symptom of a deeper problem. So teaching them how to listen to their kids when their kids are like struggling, and like instead of just punishing the children, like trying to understand what's going on with them and trying to support them, so that you guys, because I think most people that I know that play like use an excessive amount of technology are not happy with it. That's why we stream and y'all are in the audience, right? So a lot of people want to play less. And so the problem is that parents will like come at you pretty hard, and then like we'll dig our heels in. I know this because it's exactly what I used to do. And you fight them tooth and nail, right? And then when you fight them tooth and nail, like it's antagonistic, it doesn't go anywhere. You continue failing your classes, they continue getting pissed at you, and it like never happens. Like there's just nothing healthy that comes out of that. So we think that the ideal situation is for parents and kids to be on the same team and to try to like support each other. So like as a gamer, like, would you want your parents to set specific limits on you? Would you want them to support you in other things? So it's interesting because sometimes we'll even talk to parents and we'll be like, when it comes to setting limits around video games, it's like, okay, like no games from, 5 p.m. to 10 p.m. You got to finish all your homework, all that stuff, Monday through Thursday. And then if the kid does that, then it's like, okay, like LAN party on the weekend. Like you're going to order pizza. You guys are going to stay up till 4 a.m. on Friday night and Saturday night. But you got to get your shit back together on Sunday. Like that's the kind of support that we'll ask parents to provide for their kids. And it's just like that way you get your stuff done. You get to have a good time. Like that's totally fine, right? It's not like you have to do away with the video game entirely. So yeah, dude. Okay. So let's launch into our lecture. So today, chat, I want to talk to y'all about sex ed, basically. So sexual health. So the way that we're going to talk about this is it's going to be, first of all, like this is going to be primarily like a medical education lecture. So it's like something that I talk to my patients about. It isn't actually like medical advice. So you guys should go talk to your doctor about things here that seem important to you. So we're going to talk a little bit about like sexual anxiety. And what I mean by that is like a lot of people are worried about something related to sex. And so I think one of the biggest antidotes to sexual anxiety is actually education. It's one of the few instances in psychiatry where I think education actually deals like a lot of good. So like you can get a lot of benefit just by like educating people. So in other areas of mental illness, telling depressed people or anxious people to be less depressed or less anxious, or just let me explain to you that there are other fish in the sea, you won't be alone for the rest of your life, here are the statistics, doesn't seem to make a dent. Thankfully, when it comes to issues of sexuality, the amount of knowledge or understanding is so low in general that education seems to help people an immense amount. So what I'd like to do today is to share with you guys some basic information about like normal sexuality. So like, basics of like puberty and things like that, basics of like menstruation and like hormonal cycles. So I think this is something that not just women, but like men should understand too. Like we should understand, for those of us that are in relationships with women, like, what's going on with them. Like we don't have to, like, it's not like some foreign mystical thing, right? Like as a man, you can understand what's going on with a menstrual cycle. Like it's just biology, it's physiology. And so I think like equipping people with like that really basic information seems to help a lot. So some of this is going to start a little bit with normal sexuality. Then we're going to move on a little bit to safe sex. So like what are the different dimensions of safe sex? And then we're going to touch on some other like, problems that people may have. And we'll review different kinds of like birth control, different kinds of STIs and like why we use certain things when we have sex. It's not going to be like a how-to guide in terms of like sexual performance or things like that. We're not going to go into a whole lot of statistics or details about, like erogenous zones or what percentage of women are able to have like orgasm through vaginal intercourse and like all this kind of stuff. There's a lot more that we could teach, but this is going to be the basics. By the way, did you guys know that about 70% of women can have an orgasm through vaginal intercourse, penetrative intercourse? So there's a lot of stuff there that like, there's more detail, but like this is basically like when I get an 18-year-old kid in my office or 17-year-old kid, and like this is the essence of what I try to teach them about birth control, safe sex, and things like that. So basically when parents ask their kids, are you having safe sex? And the kid says yes, and they don't talk about like what that actually means, we're going to try to address that. So the first thing that I kind of mentioned is that, this is, the goal of this is to be educational, because I found that education actually does help a lot. So I'm going to tell you all the story. So I one time had a kid, and they've given me permission to share this story because they shall remain anonymous. But I had a kid come into my office and, we were talking, they came in for other reasons. And so as you get to know people, they start to open up to you about other things. And then they had some anxiety about, their sex, like stuff related to sex, and in particular masturbation. So they were like, I'm afraid that I'm not going to like be effective at having sex. And then I asked them, well, what are you afraid of? And they're like, well, whenever I like masturbate, I only reach the first stage of orgasm. And then I was kind of confused, and I was like, what exactly do you like? What is the first stage of orgasm? Like, help. I was confused by the phrase. And so then, they were like, well, I can only get to like the first part. And I'm like, what do you mean the first part? And he's like, well, like, so I was like, tell me what happens. And then he's like, well, I reach like the first stage, and then, like my erection goes away. And like, even if I try, it starts to become painful and I can never get to the stage 2 of orgasm. And so I kind of talked to him, and it seems like, so first of all, he's able to get an erection. He's able to masturbate. He's able to reach, as he calls it, the first stage of orgasm. And then after the first stage of orgasm, his penis becomes flaccid, and it becomes uncomfortable for him to continue to masturbate. So he was kind of thinking that he had maybe screwed something up, or he's been masturbating this way for a while, and like he can't ever reach the second stage of orgasm. And I was like, well, what is that? What is like the second stage of orgasm? So this is like, professionally, I'm like, what the fuck? I wasn't actually laughing then, but I was just really like confused. In retrospect, we actually both laugh about it now. But so then he was kind of explaining to me that like, when he watches pornography and like people have an orgasm, there's like gallons of ejaculate going everywhere. But when he reaches the first stage of orgasm, he has like a small volume of ejaculate, and he can't ever get to the, like the fire hydrant stage of that he sees in pornography. And so like, it took a little while for me to realize that like, his expectations of what's normal are shaped by pornography, and that's not really normal, right? And so I tried to, I'm still not entirely sure to this day. Maybe he's a different kind of kid and there are stages of orgasm, but what I understood from that is that he's actually like achieving orgasm. That's just a regular orgasm, and it doesn't last for like 8 minutes, right? Because like that's the perception that they have from pornography. And also like, they use a lot of like Viagra and other kinds of things when they film pornography and stuff. So he just had very, very unrealistic expectations of what like a regular sexual experience was like. And you can't really blame the kid, because I think a lot of us will have unrealistic expectations because we do learn from things like pornography. It's not like we're, most schools don't really have super robust sexual education classes. Some countries actually actively, try to not teach that stuff. Parents have difficulty sort of having those conversations. And so, like, where else is the kid supposed to learn? Like, is it kind of funny? Sure. I mean, I get it. I thought it would, in retrospect, I think it's hilarious, but it's also like, it's not really like the kid's fault, right? It's a consequence of the society that we grow up in and the way that we're educated. So today, what I'd like to do is share with y'all, some basic stuff about like sex and sexuality. So the first thing is, let's just talk very briefly about like normal sexual development. So, sometime between, generally speaking, like around 12 or 13 years old, most human beings will enter into a stage called puberty, which is like the stage of sexual maturation. So we'll see like different kinds of primary and secondary characteristics. For men, we'll see things like, you'll start to get erections. You may have some growth of your scrotum. You'll get the development of body hair in different places like your pubic regions, armpits, face, things like that. You'll get a deepening of the voice. There's oftentimes a period where like, boys will have like a voice that cracks. You'll see a lot of acne as well. And that's also, that's primarily driven by like hormonal changes during the puberty time. So a lot of people who have trouble with acne, sometimes the acne will resolve once they're done with the hormonal changes. In women, you'll also see primary and secondary sexual characteristics develop. So you'll also see the development of things like pubic hair and things like that, breast development. The most important thing that, most women experience is the onset of menses or menstruation. So they have an ovulatory cycle, which we're going to talk about right now because this will be important later. So there's like a cycle of ovulation, which results in menstruation. And so menstruation is when essentially the uterine lining sheds, and then women will start to essentially bleed, right? So let's kind of talk about this for a second. So this is where we're going to get into the science, okay, chat? Y'all doing okay so far, by the way? Like, are we okay with this? Is this too much? Okay, we okay with that? Okay. Okay, you're confused, so that's, hopefully we'll fix that in a little bit. Okay, so let's start to look at, hold on. So let's start to look at the, okay. So this is the female menstrual cycle. So the average female menstrual cycle, hold on a second. Problems. Okay. So here we go. One last time. Let's see if we can, if the internet or my iPad will accommodate. So the menstrual cycle involves the development of a follicle. Okay, so this is like the average menstrual cycle is, let's say, 28 days. Okay, and then once you develop a follicle, there's an egg in here, and then the egg comes out, and this is called ovulation. And then what happens is the follicle kind of starts to degrade and get smaller and smaller and smaller, and then eventually you have menses. So the way that we sort of track, so menses is also right here. So this is a cycle, right? So at the beginning, we end up with menses, we go back here, and then we start to develop a follicle. So the other thing about this is that, so we kind of mark ovulate, oh God, lagging. No, hold on. We are lagging, chat. Why isn't this working? The screen share is working. Let's try this. One more time. Please work. This is going to be hard without drawings, chat. Yes, the LH surge is coming. Okay, let's try one more time. Let's try switching Wi-Fi networks. Okay, last chance. Why isn't it? What's wrong with you? Okay, it's saying it's mirroring. Let's see. All right, here we go. Got it. Okay, so we're going to start over, okay? So the average female menstrual cycle is 28 days. That is because it is aligned with lunar rhythms. No, it's not aligned with lunar rhythms. It's because of biology. So we start out with, so let's actually start in the middle with ovulation. So there's this thing called a follicle, and a follicle kind of develops, and then we get like a big follicle, which has an egg inside, and then at ovulation, the egg comes out. After that, the follicle kind of gets smaller again, it degrades, and then over here we have menses at day 28, or actually over here is menses at day 0. Okay? And so this is like where we have menstruation. So basically, like once we have an egg that leaves the follicle, this is the zone. We've got basically 1 week where you can get pregnant. Because now we've ovulated, we've got an egg, we're ready for the sperm. If the sperm meets the egg, then we will get a pregnancy, right? So we'll form like an embryo or a zygote. And then that follicle will go and implant in the uterine lining. So this is like, let's say this is the uterus. Here's the uterine lining here. And so this egg will go over here and implant over here. Here are the fallopian tubes. Okay? Ovaries. So that's kind of what happens. So over here, like if by the end of 1 week, if we don't have a uterine lining that has an egg implanted into it, essentially what happens is we get all of this uterine lining that sheds. So this all goes away and then kind of comes out as blood. So this is the process of menstruation. And then you kind of prepare the whole cycle again. Now, the next thing to understand about this whole cycle is that it's hormonally driven. And this is going to become important when we talk a little bit about different kinds of birth control, okay? So essentially what happens during this time is that we've got so we've got this hormone here called FSH, which is going to slowly increase. And then we've got another hormone called LH, which is going to be like relatively low. And then surges over here, which triggers ovulation. And then it kind of stays low again. And so FSH is follicle stimulating hormone. So this is going to cause, FSH is what causes these follicles to grow. And so FSH over time is going to actually kind of go down. Like once we have our follicle that's ready to go, then FSH decreases. And then this LH surge that's in blue is what triggers ovulation. So essentially FSH is going to prepare us for ovulation. The LH surge is what triggers this egg leaving. And then both hormones tend to go down as we enter the luteal phase. And we end up with menses after that, okay? This is going to become important in a second when we talk a little bit about birth control, okay? So let me grab my notes. So this is the process of menstruation. Any questions? We'll talk about PCOS and stuff like that, okay? So menses is the process of shedding the uterine lining. So like when an egg does not implant, let's use purple. So when this process does not happen, okay? So if this egg gets fertilized by a sperm, it'll go and it'll hang out, it'll implant into the wall of the uterus where it will start to grow into a child. And if that process doesn't happen, the body sort of realizes, okay, it looks like we don't have a viable embryo that we can't carry to create a child. So all of this uterine lining that we built up, we're actually going to get rid of. And then we'll start the cycle all over again. Okay, so that's what menses is. It's essentially shedding the uterine lining. Interesting tidbit. Unfortunately, menses is one of the only necrotic processes in the body. So when a cell dies, normally it goes through this cycle called apoptosis, which is programmed cell death. Interesting aside, okay? So, did y'all know that between your fingers, you used to have webbing? So our fingers used to be connected by skin. But what happens when our body is developing is like there's skin that connects our fingers, and then the body sort of realizes, the skin in the middle realizes, hey, we don't need to be here anymore. So it actually goes through a process of programmed cell death, and it dies. So sometimes when cells get old, sometimes if cells get cancerous, they'll actually like auto-destruct. And the cool thing about apoptosis is that generally speaking, when it happens, it's not painful. It's like a normal thing. It's like basically we're shutting down the cell. Necrosis is different. Necrosis is what happens like when I get, crushed by like, a brick, or when I get damaged in some way. That's like cell death that was not planned. And so necrosis releases a bunch of inflammatory things, releases substance P, which causes pain, which is why like menses is so friggin' painful and uncomfortable, because it's one of the only necrotic processes in the body. It's essentially like getting it's taking internal damage as opposed to like winding things down, which is what apoptosis is. So that's part of the reason why menses is like tends to be like quite uncomfortable and quite painful for women. There are other things that kind of complicate that. But I think it's one thing to kind of understand as like a dude, like it helped me kind of recognize that, I don't think we sort of realize as men, we're not taught that like there's actually like a part of your partner's body that is like dying, and it's painful and uncomfortable and inflammatory and causes like, that's why you get like, belly pain, abdominal pain, discomfort, bloating. All that stuff is happening because you have this necrotic process going on, which is not like as peaceful and organized as the apoptosis. Oh, the egg cell necrosis as well, but the egg cell is tiny. It's just one cell. You have a whole uterine lining that is gonna like essentially die. I mean, it gets sloughed off, right? And that's what menses is. Okay? Anyway, enough about menses. Let's move on. You guys have... Yeah, every month. It ain't easy. So I don't think most men, really ever experience something along the lines of like... It's like kind of getting the flu, like on a monthly basis, right? It's just like this period of time for 1 week where you're just like kind of feeling crappy and in some relative amount of pain. It's just... And it happens every damn month, right? Until menopause, which is a whole other mess and uncomfortable. But, okay. So basics of menstruation. That's going to become important in a second because we're going to talk about birth control. So next thing that we're going to talk about is like, so now that we have a basic understanding, okay, so puberty happens, right? So people start to develop. Women have this hormonal cycle that results in menses. If you have sex during the week, during that 1 week, or you can even have it a little bit before, but there's basically a 1 week window, I'm oversimplifying, where a woman can get pregnant every month, okay? And so when we talk about, so let's move on a little bit to safe sex. So like I said earlier, a lot of times parents will ask their kids, hey, are you being safe? And the kid is like, yes. And nowhere do we ever discuss like, okay, what are the dimensions of safety? So when I talk to my patients about, safe sex, I will talk about 3 or 4 different things. So one is I will talk about birth control. The second thing I will talk about is STIs, because oftentimes those two things get confused. I know it's kind of weird. The third thing is sometimes we can talk about pain, which is like there are some conditions that are relatively common, which result in people having uncomfortable sexual experiences. The challenge with those conditions is that the person feels like fundamentally messed up. So there's a lot of shame associated with these conditions. So sometimes, people think that they're like not able to have sex, or like that everyone else is enjoying sex and they don't enjoy sex. It's actually painful for them. So they think that there's something wrong with them. And in a sense, there kind of is, because there can be like a medical problem, but it's not like an issue of like you as a person. It's like your body may be responding to sexual activity in like a, in a pathologic way. So there are actually conditions that lead to pain during sex. And so sometimes it's about educating people about that kind of thing. So just to give you guys an example, I had a female patient who had a lot of difficulty having sex, and it turned out she had a medical condition, but like she didn't realize that for years. She would just, try to engage in sexual relationships with men and found it incredibly, incredibly painful. And so it was like she just thought like she was busted as like a human. She was like, I can't ever, I can sexually gratify my partners, but it's like painful every single time I do it. I care about them so much. I even love them. And like, but like something's wrong with me. Like I can't, like, I don't know, like I don't enjoy it. I feel like vomiting every time I have sex. And it's like, she comes into my office and it's like, whoa, right? It's so hard because she understands that in this society, like sexual pleasure and sexual gratification is a part of relationships. She feels really guilty for like the way that her body responds. And it turns out that there could be a medical reason for it. So that's why we have conversations like this. Okay. And then the dude too is like he's kind of at a loss as well. This was a situation where I talked to her partner, her fiance as well. And so like he was kind of like, I want to respect her boundaries, so I'm totally fine, not having sex. And then like he's willing to give it up. And then she feels super bad and he feels super bad, and like no one feels good about anything, right? It's despite all of the love and all of the caring, everyone's just like stressed and nothing's going well, and they don't know if they're ever going to have kids and all this kind of stuff. So this is why like a little bit of education actually goes a long way. Okay. So let's talk about the different dimensions of safe sex. Okay. So I don't know if we're going to get to things like consent, but let's talk about safe sex. So the first thing that we're going to talk about, so when you have safe sex, the first thing that you need to watch out for is STIs, or sexually transmitted infections, okay? So when we talk about STIs, so for those of you that don't know, there are bacterial infections and there are viral infections, okay? So oftentimes bacterial infections are things like gonorrhea, chlamydia, stuff like syphilis. Okay. So like oftentimes these bacterial infections will cause things like pain, discharge, which is exactly what it sounds like. It's like there's like pus or goop coming out of your sexual organs. The good news about bacterial infections is that like we can basically treat it with antibiotics. Okay. So this is what's super sad, is that if you get a bacterial infection, like you can just take a course of antibiotics, just like get yourself some Bactrim or something like that. And then in like 6 or 7 days, the infection will be cleared. You'll be totally fine. Okay. And it's like not that big of a deal. Generally speaking, there isn't any long-term damage. This is why it's also incredibly sad that people are not educated to this kind of stuff. So if you do have a bacterial infection, what will happen a lot of times is like let's assume a male patient for a second, your penis will start to hurt. It'll become red or swollen. You'll start to get goop coming out of it, right? Discharge. We're not going to show pictures, but, and then what happens is you get embarrassed. And like, you're like, oh God, like what is wrong with me? Like, what will people think? Like, will anyone find out? And so your embarrassment causes you to not seek medical care. And you're like, I hope it'll go away. It's the tried and true. It's the first, medical intervention that most human beings make. The first medical choice that most human beings make is, I hope it goes away, because it's cool, because our body like takes care of most things, right? You get a mosquito bite, it's not like you need to do anything. Your body will take care of it. You sprain your ankle, it's not like you need to do anything, but your body will take care of it. If you have diarrhea, you start vomiting, you get fever. Like, I'm just gonna you're hungover, you get drunk. You're like, our body will take care of it. So a lot of people will just let their body take care of it. That's a terrible idea when it comes to STIs, especially bacterial ones, because you can take a 7-day course of antibiotics and you could be fixed. But instead, what will happen, and I've seen this and it's super sad. Syphilis is a good example of like penicillin treats syphilis, okay? But like when people don't treat syphilis, and syphilis is also kind of interesting because it actually presents with something called a chancre, which is like a sore on, let's say, the penis that is non-painful. So like you wake up one day and you're like, there's like a little like dot on your dick. And then like over time, like the dot grows and then you're like, well, that's kind of weird. It doesn't hurt or anything. It's just a weird, like it's like an ulcer on the penis. And then it can even go away, and then people are like, okay, fine, or like it'll come and go, but it doesn't really hurt. People won't take care of it. And so then syphilis can spread to places like your spinal cord and like cause nerve damage and like all this other kind of terrible stuff. And the sad thing is that it's like super treatable. So generally speaking, if you have sex with someone and then something weird happens to your genitals, they start to hurt, or you start to see weird marks on them or things like that, go see a doctor. Okay? Now, what's a little bit more troubling, we'll get to what else to do about this in a second. So what's more troubling is viral infection. So herpes is a good example of this. HIV is something that people are, understandably concerned about. So these are kind of interesting because these are lifelong. So once you get a viral infection of herpes, it's never going to, the infection will stay there forever. Something like HIV too is a lifelong illness. So once you catch it, you got it. So there are a couple of interesting things, though, when it comes to herpes, and we're going to go off on an interesting tangent here as well. And this has to do with viral evolution. So if we kind of think about, let's say I'm a virus, okay? These are spike proteins. It's not a sun. If I'm a virus, and I infect a human being, I've got a couple of different strategies, right? Like I can be very, very infectious and then kill the human being. Like let's say I'm Ebola. Right? I can kill a human being and then in the process I'm bleeding and stuff and I infect other human beings. But generally speaking, these are not the most successful viruses. What's super successful is herpes. And so what herpes does is kind of bothers you but doesn't really affect your survival. And so essentially what happens is some viruses that we get will actually become relatively dormant and not too much of a pain in the ass. So I think somewhere between 25 and 40% of the human population has herpes. And then you'll get these sores that will come and go. So you'll get flares of herpes. And then you can start medication during those time that will reduce the sores and stuff like that. But for many people, I think maybe even 20% of people will never be symptomatic, or maybe 40% of people will never be symptomatic with herpes. So they'll never have a sore or anything like that. The virus is just hanging out in your body. And you can even potentially have a period of what's called asymptomatic shedding. So this is something else to know about herpes, is that even if you don't have any active virus, you can still transmit it to other people. HIV is sort of the same way. So remember that HIV leads to something called AIDS, right? Which is acquired immunodeficiency syndrome. And so for many, many years before people develop AIDS, they will have active viral replication and can spread it to other people. So HIV is a virus that attacks your immune cells. And so AIDS is not actually direct damage from the virus. What happens is HIV destroys your immune system, and then you get all of these infections that normally human beings don't have to deal with because your immune system just takes care of them. It's kind of if you're playing a video game and you can normally you're playing at a high MMR, and then someone goes and unplugs your mouse and your keyboard, and then suddenly you start losing to noobs. The reason you're losing to noobs is because you can no longer play the game. That's why HIV is such a devastating disease, because it cripples your body's ability to actually fight it. The key thing to remember for the scope of this talk is, first of all, even if you've never had symptoms of these things, you can still have them, right? So this is safety point number 1 with viral STIs. You can be asymptomatic and still have it. You can be asymptomatic and still spread it. Right? Your partner can even be asymptomatic and you can still have it. So this is why, if you've had, we'll talk about this in a second, if you've ever had, sex with another human being without a condom or a female condom or something like that, then you are at risk of having an STI. The only really case that I can think of where that's unlikely is if both of you have never had sex with anyone else. And even then, in rare situations, you can get viral transmission of things like HIV during birth and stuff like that if your mom had it or whatever. But usually, doctors know about that because we test that kind of thing before mothers give birth. But generally speaking, if your partner has ever had sex without a condom with anyone, and you have had sex without a condom with anyone, you are at risk of having a viral STI. So this is where everyone should get tested. Right? Because you never know, like, if your partner's lying to you or honest or whatever. So generally speaking, for young sexually active patients, I recommend they get tested at a minimum of once per year. Depending on how high risk you are, you can get tested even more. Okay? So next thing to kind of think about is, all right, so like, how do we prevent these things? So this is where the condom comes in. So the condom is the best protective barrier against, transmission of both bacterial and viral infections. So wearing a condom has two goals. So condom is to protect against STIs. And actually, it's interesting how many people don't realize this. I personally find it mind-boggling, but, it just speaks to how our systems of education are. And the second is to prevent pregnancy. And these are two distinct goals, okay? So this is where, like, I've had patients that, will be like, oh yeah, so like I hooked up with a girl and I was like, okay, were you safe? And they were like, yeah. And then I asked the question, like, what do you mean? And it's like, oh, like, I asked her, she's on the pill. It's like not a big deal, right? So like safe, sometimes people mean like getting pregnant, and sometimes they mean like protecting against an STI. And it's like, so then I'll ask my patient, I was like, did you actually use a condom? And he's like, no, I didn't need to because she's on birth control. It's like not a big deal. Right? And even for people who are like not even in the hookup stage, I'll talk to people who are in like monogamous relationships. Yeah, I've been dating a girl for a year. We used condoms for the first 6 months. And then like, then we stopped using condoms because she was on the pill. And like, I trust her. And it's like, okay, fine. Even if you trust her, has she ever had sex without a condom with anyone else? Have you ever had sex without a condom with anyone else? And has she ever been tested? And have you ever been tested? The fact that you're asymptomatic does not mean that, she could have asymptomatic HIV. You could have asymptomatic HIV. So condoms are the best way to protect against STIs, outside of, abstinence and stuff like that. And so that's really our goal. So like just thinking about, Dr. K's like two things that you should talk to a doctor about. One is that if you've had sex with another human being without a condom, and both of y'all are not virgins, and even if they say they're a virgin, because you never really know, right? It's a good thing to just go ahead and get tested. It's a cheap test. Most doctors will order it, just so you'll have the peace of mind. And then when if you do have sex with someone, use a condom, because even if they're on birth control, like you just don't know what they've got. So like gonorrhea and chlamydia too can be asymptomatic for a while. And that's like how they spread, right? Because it's not like they, like they're actively replicating, and like there's not discharge and pain coming out of your penis or your vagina. And then you have sex with someone, and then like they transmit it, or you transmit it, and then you get it, and that's how it works, okay? Questions about STIs? Okay, next thing we're going to talk about is birth control. Okay, so the first thing to understand is that there are many kinds of birth control. Now, Dr. K's rusty on my statistics, but I think this is right, but I haven't really checked these statistics in like 15 years. So methods of birth control. Number one, the pull-out method. So if you guys remember, there is a menstrual cycle, right? So what some people will do is like they'll, try to time it. So this is the timing method, where we're only going to have sex when, during the 3 weeks that we're not ovulating. So that's number one. Pull out is number two, which is like, if the dude doesn't ejaculate in the vagina, then, that's a method of birth control. So I want to say that the pull out method is like 60 to 70% effective. So what does this mean? So last time I checked, which was some time ago, the statistics that I'm going to cite are going to be if a couple is having sex over the course of the year, what is the likelihood they will wind up pregnant or not? So let's look at it this way. So this is efficacy. And what efficacy means is preventing pregnancy. Okay? And so this is like, 100 minus this number is the percent chance that you'll get pregnant over 1 year. Okay? So what this means is like 30 to 40% of people who use the pull-out method will get pregnant. I think the timing method too is like pretty bad. It's like maybe a little bit higher. I don't really remember the exact statistic. So 20 to 30% of people who like, use this method will still wind up pregnant if you have sex over the course of a year. And what some people may be saying is about like the pull-out method, doesn't that, what's up with that? Like, so what are the factors? So the first is that sometimes before you actually like have an orgasm and ejaculate, you'll actually release some degree of semen. So there's like, there's the pre-ejaculate, which can sometimes have semen. So that's one thing. The other reason why it is so effective, because still at the end of the day, like 2 out of 3 people that use the pull-out method at the end of the year won't be pregnant. And that's because remember that, 75% of the time, a woman isn't actually like 75% of days of the year, the average woman is not able to get pregnant, right? So what we're kind of talking about is like a series of like, confluence of events. So first of all, she has to be in the ovulatory window. And then like you have to have maybe pre-ejaculate, or sometimes you screw up or like don't screw up. Like even if you screw up, there's a 75% chance that your partner's not going to get pregnant, right? So that also depends on things like frequency of sex and things like that. So these are pull-out method, timing method, I don't recommend them. Next thing to think about is condoms. So condoms are actually 90% effective at preventing pregnancy. And what is that? How does that work? Well, so it turns out that a big part of like condom effectiveness is like user error. So what this sort of means is that if I have a partner and I'm going to, okay, we're lagging. If I have sex over the course of a year, and like 9 out of 10 people who use condoms and have sex over the course of the year won't wind up with a pregnancy. 10% of them will. Okay, so like some of this is like, it's a little bit unclear exactly what's happening. I don't think that generally speaking, condoms are faulty. Some people will store them in places like their wallet or things like that, where it may degrade like the latex barrier or things like that. I think that these are, if memory serves, these are like pretty naturalistic studies. So essentially what they do is they'll ask like, 100 people, do you have sex? And they'll say yes. And they'll say like, did you get pregnant? Or do you use a condom? They'll say yes. And they'll say like, did you get pregnant? And then 10% of people will say yes. So we kind of rate the efficacy of condoms at 90%. Okay. Which is actually terrifying to me personally. So next thing to kind of think a little bit about is the birth control pill. So what the birth control pill basically is estrogen and progesterone, but there are progesterone-only versions. And the birth control pill, I think, is something like, 95 to 97% effective. So we're talking about 3 to 5% pregnancy rate. And the key thing about the pill is you basically are taking hormones for 3 weeks out of the month. And then if memory serves properly, there's like 1 week where, it's not quite placebo, but there are different hormonal formulations that will allow you to menstruate. And basically the way that birth control pills work is we're adding estrogen and progesterone, which, by the way, this follicle produces progesterone. And, these hormonal things are creating estrogen. So essentially what happens is like when you have progesterone and estrogen floating around, these are going to block production of GnRH, which in turn will block production of FSH and LH, right? So for those of y'all that are kind of familiar with this, basically the way that our body works is through hormonal feedback loops. And so if estrogen and progesterone are low, GnRH from our hypothalamus gonadotropin releasing hormone will increase, which will cause these to increase. And as these increase, we'll go towards ovulation. And as we go to ovulation, we're going to produce more progesterone. So then this then goes up. And then once this goes up, this goes down. You guys see it's like a feedback loop. Okay, so we can draw it out over here real quick. So we've got GnRH increases FSH and LH. This is a little bit of a simplification. Causes ovulation, which in turn creates progesterone, right? And these are actually going to create estrogen over here too. Let's go this way. And then these in turn go and block this, right? So it's like a feedback loop where the greater this is, eventually it'll produce downstream hormones that will reduce this growth. And as we reduce this growth, the inhibition decreases and it increases GnRH. That's how our body like balances things. So if we think about things like our blood pressure, right? So how does our body maintain a blood pressure of 120/80? It has a system of feedback loops. You have things like baroreceptors. So what a baroreceptor does is measures the stretch within your blood vessels. And so if the pressure is greater, it's going to stretch more, activate the baroreceptor, and cause you to decrease the strength at which your heart pumps, which will reduce the amount of stretch in your blood vessels, which will then tone down the signal on the baroreceptor. You guys with me, or is that like too complicated? You guys get that? No. Okay. Okay. The general principle is there's a feedback loop, right? Like everything in so our body maintains a blood pressure of 120/80 because it's got like signals that make sure that if we go below 120 or 80 over 80, we'll increase our blood pressure, and we have ways of detecting that. And if we go above 120/80, we have ways of detecting that, and we'll drop our blood pressure. Okay? We'll talk about mood and stuff in a second. All right, so let's go back. So why is birth control only 95 to 97% effective? Once again, it's user error. So generally speaking, if you're taking your birth control properly and you're taking it on time and stuff like that, it is theoretically close to 100% effective. But it turns out that human beings sometimes don't take their pills on time, they miss a day, whatever. And so if you don't take your pills properly, you have a 3 to 5% chance of getting pregnant. So then, after that, what we've got is the patch or the implant. So then what people decided is we're going to develop essentially a birth control patch or implant. So what this is it's like something that you can get like on your arm usually, like under the skin, like an implant that will release progesterone, estrogen and progesterone. And I think these are essentially 99% effective. So once you remove user error from the equation, 99 times out of 100, like people won't be able to get pregnant. Okay? So this is where like, the hormones themselves are damn near perfect. It's just once you force people to take pills, it becomes problematic. So for example, this is why you should actually consult with a doctor. Like if I have a patient with ADHD, I'm going to, talk to them about getting a patch or an implant over the pills. Because if you've got ADHD, your likelihood of user error and forgetting to take pills is greater. Now, this is a conversation with the person. I've had a lot of patients with ADHD that they may forget everything else in the universe, but the one thing that they always take like clockwork is going to be their birth control medication. So it's not like necessarily like ADHD people can't take birth control meds. It's just you have to have a conversation, and this is where the individualization of your condition is important, okay? And then the last thing that we're going to talk about is an IUD. Or not last thing, but the last birth control for women outside of surgery is an IUD. So this is an intrauterine device. So remember over here, what an intrauterine device is they take like a piece of they stick a device into the uterus. Now remember that the uterus is like beyond the vagina, right? So here's the cervix, which is like the gatehouse to the uterus. And then here's the vagina. So it's something that's implanted within the uterus. So oftentimes these devices are made of copper. And since they're copper, they actually cause inflammation in the uterine wall. And this inflammation in the uterine wall prevents the egg from being able to implant. So you can actually create a fertilized egg, but it just can't ever implant into the uterine wall. So it's never going to grow. You're never going to get pregnant. So IUDs come in just the copper variety or copper plus hormone, usually progesterone. And these are also like 99.9% effective. Maybe it's greater than, I don't know that it's 99.9. I actually don't know that. But they're also removable. So the copper one lasts for about 5 years, or maybe longer. Actually, I think the copper one may last longer. The hormonal one, so it also releases progesterone, which if we go back up here, we remember that it's this progesterone that essentially acts as your body's internal birth control. So when we take birth control pills, we're actually like trying to simulate this thing that prevents you from getting pregnant. Okay, so for example, and the term progesterone means progestation. So even the placenta will release progesterone to prevent like you from ovulating while you're pregnant, if that kind of makes sense. Okay. So these are 99% effective. You know, they're in your body for, I'm a little bit rusty on this. I think the hormonal one is 5 years. The copper one may be more. It may be like 10 years. I'm not entirely sure. But this is basically, you know, so you have a 1% chance or less of getting pregnant. So if you were a young sexually active woman who doesn't want to worry about anything and is not planning on getting pregnant for about 5 years, this is what I would recommend. So for most of my patients, when they ask me, Dr. K, what kind of birth control should I take? Unless they've got other factors, which we'll talk about in a second, like basically like IUDs are great because you kind of fire and forget. And then when you're ready to get pregnant, you can take it out, right? Or you have to change it out every 5 years. So it tends to be like very, very like, you know, there's no hormones being put in. Even with implants and patches, you have to kind of get them changed. It's like you go once, you get an appointment, you get an IUD, like they're really fantastic. So outside of this, we also have procedures, right? So we have tubal ligation, which is getting your tubes tied, which is damn near 100% effective. And then we also have vasectomy, which is close to 100% effectiveness. And what this is when you have a tubal ligation, remember that the follicle starts here in your ovaries and it travels down a tube and then will like ovulate. And so a tubal ligation is basically closing this off. And so then your ovaries can never, the follicles and eggs from your ovaries can never get to your uterus, which basically makes it impossible for you to get pregnant. Now, there are some risks with tubal ligation, like sometimes you can have like, you know, an ectopic pregnancy and stuff like that, but that's kind of beyond the scope of this. An ectopic pregnancy is a pregnancy that implants somewhere outside of the uterus. So sometimes you can even get implantation of an egg over here in the fallopian tube, and that can be really dangerous. But it's quite rare. So, and then vasectomy is when, you know, men will essentially have, so we've got, you know, our scrotum, and then we've got tubes that connect to our penis. And so a vasectomy is when we kind of snip these so that the sperm can never get into the penis. And yes, this is a bad penis on purpose. I'm sure I could draw a slightly better anatomical penis, but I'm choosing not to. Okay, chat? Because fuck y'all. Okay. Okay, so vasectomy and tubal ligation. So some of these can also be, they can be like reversible to a certain degree. But generally speaking, when you're done having kids and you never want kids again, this is like the birth control of choice. Okay? So questions about birth control? Okay. And then if you want to troll, if you guys want to get into it, then there's another 100% effectiveness of birth control, which is being challenger rank at League of Legends. Right? This is something that is male birth control that results in 100% efficacy of pregnancy prevention. We good? Okay. So, okay, so that's birth control. So you guys get that? So like, okay, big picture for a second. All right, so when we talk about safe sex, two major dimensions of safety. One is STIs. Key thing to remember about STIs. They can be asymptomatic for a while and you can still transmit and get them. So if you've been sexually active without a condom, you should probably get tested at a minimum of like once a year. For patients that I have that are more high risk, I'll recommend more frequent testing. So best way to protect against STIs are to get to use condoms. The other thing that I recommend in terms of like safe sex is like if you don't want to use a condom, you get tested, your partner gets tested, you guys are in a trusting, ideally monogamous relationship. If you're in a poly relationship, I guess it's fine as long as everyone gets tested. So everyone within your sexual group gets tested and is going to be exclusive with each other, so you can't get contamination from the outside. And then once you have birth control, like you can start to, have sex without a condom, no big deal. Second reason we use condoms are to prevent pregnancy, right? But that's when we open things up to birth control. So condoms tend to be the number one male form of birth control. Vasectomy is quite extreme. And then, like there are lots of other forms that primarily have to be on the woman's side. And those tend to be, like a lot of people will start the pill, the birth control pill, which, you have to take every day. There can be implants. You guys can do things like IUDs. So you just have to figure out, what's the right move for you and what you're comfortable with. Okay. So having safe sex, in summary, I think involves like two things. One is like protecting against STIs, and the second is protecting against pregnancy. Yeah, you can also do shots. So there's like other forms of birth control and stuff. Like this isn't complete by any means. So for example, we didn't talk about fungal infections. This can be kind of annoying because like a woman can have a fungal infection. You can pass it to a man. The woman's will self-resolve, and then the man gets it and then passes it back to the woman. You can like pass it back and forth. So yeah. Okay. Now what we're going to do is talk a little bit. I see that there's some questions. We'll get to those in a second. So now we're going to get to a couple of common conditions that I think like people tend to deal with. So a lot of these conditions, so this is like the normal sexual stuff. And then there are a lot of things that people will deal with that result in pain and discomfort that they're kind of not aware of, and educating about these conditions can be really helpful at having like a healthy sexual relationship. Okay. So the first is we're going to talk about phimosis and vaginismus. So phimosis, so for those of you that don't know, here's a bad penis drawing again. There is this thing called the foreskin, which is like a piece of skin that kind of covers the penis. And when the penis becomes erect, the the penis kind of, the penis elongates, right? And then the foreskin kind of hangs back over here. So there's actually a condition called phimosis where the foreskin is basically like very tight and you can't really pull it back. So when you get an erection, like you can't open up the foreskin, and you can, like the penis has difficulty like expanding out as it fills with blood. So what this basically results in is like painful erections. So phimosis, thankfully, is like quite rare. Usually involves like some kind of scarring or accident with the foreskin where it develops scar tissue, so it's not as flexible as it used to be, but like can result in a lot of shame and like, oh my god, like I can't get an erect, or my penis is small, or like it hurts so much every time I get erect, so I have to stay away from women and like, or men, or so that's phimosis is just an example of like a rare condition. The reason I bring it up is simply because there are like biological reasons. Like if something involving your sexual organs feels very, very uncomfortable to you or painful, like go see a doctor, right? Because you could be one of the few unlucky people that has phimosis. What's a little bit more common is vaginismus. And this is a spasm of essentially like the outer muscles of the vagina. So what that means is like when you have a muscle spasm, so remember that, the outside of the vagina has lots of muscles. And so when they spasm and contract, it like they contract and like nothing can enter. So a lot of times what'll happen is you'll get, a lot of contraction and spasm, which means that anything that if you try to have penetrative sex, you're going to get a ton of pain. And then like the problem with vaginismus is that there appear to be, there are different kinds of treatments for it. So you can do things like vaginal dilators. Also, things like psychotherapy can be effective. So we know that like vaginismus does have a mental component. Sometimes you'll have people with a history of trauma who develop vaginismus. And so vaginal dilators are like, using these particular devices that will slowly allow the spasm to kind of relax. So it takes a lot of time and effort, but this too leads to a lot of, shame, self-worth issues, like leads to a lot of relationship problems because the woman doesn't know what's wrong with her. Like it just hurts a lot every time she has sex, and she loves this person and she wants to have a relationship with them. The dude is kind of like, doesn't know what to do about it. They're kind of confused. People will try lube because they're like, okay, maybe it's an issue of lube. So the point here is that if you're having pain or discomfort during sexual intercourse, you should go see a medical professional, because it's not that you're fundamentally busted or broken or whatever. It's just that, like there may be actually something medical going on. So other conditions that, cause pain, this isn't really related to sex directly, but endometriosis, I'm just kind of including. So some women will have endometriosis, which is the presence of this uterine tissue. So remember this uterine tissue over here? In places outside of the uterus. So sometimes you'll get a spot of uterine tissue here. Sometimes you can even get it in the abdomen, so you can get it like outside of the uterus. And then what happens is when you go through the necrotic phase of menstruation, this stuff, because remember, this is all mediated by hormones, right? And hormones travel all over your body. So you get all these spots of uterine tissue that start dying like all over your abdomen. And it's incredibly, incredibly painful. And so like some women are just really, really surprised by like how bad menstruation is. Like they're in tons of pain. It feels like the pain is even like outside of the uterine area. And so endometriosis is a very, very unfortunate condition that causes like a lot of pain. So people are also asking about, menstrual cycles and mental health. There are lots of good correlations. There are patients that I've had that starting them on birth control is like helps their depression. So I'll use birth control as an adjunctive medication to treat their depression because there are mood fluctuations with all these hormonal fluctuations. Other things that I'll do with people who have really, really bad PMDD, which is premenstrual dysphoric disorder, or not necessarily PMDD, but who have like menstrual, like really, really bad periods and really, really bad moods, sometimes I'll actually send them for an endometriosis evaluation. Because sometimes the reason that your mood is so damn bad is because like there are parts of your body that are dying like scattered throughout your abdomen. And it just hurts like hell. And so you're cranky and you don't feel like doing anything, and you kind of get sad and depressed, and you even get a little bit of the PTSD, so that next month rolls around and you're like, oh my God, it's going to happen again. And it happens again and again and again and again and again and again and again. And so like endometriosis, I kind of include it for the sake of completeness. It's not really like a sexual problem. It's not really related to sex. I just include it as like something that happens to people that's relatively common, that can affect your mood, can affect a lot of stuff around menstruation, and you feel like having sex or don't feel like having sex. Kind of a PSA. Other conditions that, people will kind of mention, this is sort of a random smattering, so it's not like I've picked the most common. So hypoestrogenism is a good example of something that leads to like vaginal dryness. So this is like another thing that's filled with lots of shame and self-worth issues, is that some women have either a low level of estrogen or low response to estrogen in the vaginal tissue, which results in dryness. If there's dryness, there can be pain during intercourse. So, treatment for this is just things like using lubricants. Sometimes even starting birth control can help. Right? And so there are just a lot of things out there that can make sex painful or uncomfortable. And as long as we know, because what tends to happen, like psychologically, let's just talk about this for a second. If you don't know about any of this stuff, and you just hear that sex is amazing and everyone's getting laid on Tinder and whatnot, and like people romanticize it in movies and TV shows, and if you're a Netflix producer, you sprinkle in random sexual scenes in places that they don't belong for, I don't understand why, but whatever. And then like what happens is like there's a societal perception of what sex is supposed to be like. And so like if you don't live up to that societal perception, it results in like lots of shame because you're like, I'm kind of screwed up. Right? So other good examples of that are like, things like penis size, where A lot of people are concerned about the size of their penis. Even I've unfortunately made fun of people with micro penis in the past. It's something that I regret. And the truth is, like, I don't know if you guys know this, but there are these people called lesbians, and they're able to have healthy sexual lives, and they actually don't even have penises at all. They have like the tiniest penises on the planet, and they actually do fine. And so it turns out that, like, penis size is actually like not that important. So even if people, there's a lot of stuff involving shame and self-worth and people like feeling like their body isn't good enough. And it turns out that having a healthy sexual relationship is just about really understanding like yourself, understanding your body, understanding your partner. It doesn't come down to, the size of your penis or any other like arbitrary characteristic. So just keep that in mind. Okay. The last thing that we're going to cover today is just like a couple of surprisingly common sexual problems. So we're going to talk about premature ejaculation, and death grip syndrome. This one is an actual medical thing. This one is something that Dr. K made up. But I see way too much. Okay, so let's talk about this. So premature ejaculation is when people ejaculate very quickly. At the end of the day, there are a lot of different things that you can do. There's a lot of, shame associated with premature ejaculation as well. There are treatments for it. So oddly enough, you can start people on SSRIs for premature ejaculation. So one of the side effects of SSRIs, which are antidepressant or anti-anxiety medication, is that like they make it harder for you to climax. So sometimes you can even use this with people who prematurely ejaculate. If they start an SSRI, like they can essentially last longer. Other things that you can do is you can, wear a condom, so that reduces the amount of feeling you have and things like that. There are just like general things that you can do for premature ejaculation. You can use mental distraction. I know it's kind of weird, but you can think about video games while having sex, and that'll actually like help you last longer because your mind won't be so into the sex. It's difficult to do, but it does work. And then there are other things that you can do just as you start to have sex on a more regular basis, as you get to know your partner. Oftentimes premature ejaculation will actually, I swear, guys, I'm not trolling you. I'm serious. So there's actually like, you can use mental distraction and think about non-sexual things, right? Because if we think about the process of arousal and ejaculation and climax, like arousal is a huge part of it, right? You don't just walk around ejaculating. Right? Like I realize that some of y'all are going to punish me for saying that, but it's true. So the truth is that fuck me. Such a bad idea. So the truth is that arousal has a lot to do with reaching climax. And so you can use mental distraction to reduce your internal state of arousal and will allow you to ejaculate later. Interestingly enough, there are also like techniques of tantric meditation, which we can talk about in a second, that also can help people with premature ejaculation. Other things that you can do for premature ejaculation, I know it's kind of weird, but I've seen a lot of self-resolution in committed relationships. So just like slowing things down and almost like training yourself. So like training yourself with your partner as you get close, kind of slowing down, taking a step back, like restarting, like you can just sort of like retrain kind of behaviorally, like your body's response, like almost in a biofeedback way, if with kind of time and effort and dedication. Death grip syndrome is something else entirely. And this is where when people masturbate for long periods, I'm talking about men. So when they masturbate for long periods of time, especially without lube and, using hand, and like for years and years and years, what happens is you can also like train your nerves to respond to a particular kind of stimulation to reach climax. And so when it's kind of bizarre, but some people who like, let's say you've never had sex and you've been masturbating for 10 to 15 years, and then you have intercourse for the first time, and the sensations provided by intercourse are actually quite different from what your body has gotten used to. So, the lubrication and the pressure and things like that it tends to be a little bit less than what you can do with your, the lubrication is greater and the pressure can be less, which results in a different physical sensation, which results in a difficulty to attain climax through sexual intercourse. This too can be sort of fixed through training. So the first thing is that, using lube and a lighter grip. And it's going to feel kind of weird because a lot of people that, who go through this experience will it kind of feels unsatisfying to masturbate in that way, but you kind of got to do that. Or you can start to have more sex and then your body will reacclimatize. Aren't these a solution to one another? Sort of, right? So they're kind of like opposites. All right, so that's kind of just a couple of random other things. So this lecture is by no means complete, but when it comes to, people that come into my office and we try to talk about safe sex, we haven't really talked about consent really at all, which I think maybe is just a whole other lecture because we've been at this for over an hour and 15 minutes now. But the goal is really to just share with y'all some basic information about sexual education. It's not to be memeish, which I know we did, but it's really just to empower yourselves to understand a couple of basic things. One is what does safe sex mean? From an STI perspective, from a pregnancy perspective. Second is, what are some common problems that people will run across? And the main message there is not for you guys to self-diagnose, is not to diagnose yourself with these things, but to recognize that if you have any kind of pain, any kind of discomfort, if something about your understanding, your perception of what sex should be like, is you have a perception of sex and you have an actual experience of sex and those don't line up, one of the first things you should do is go see a medical professional, because it turns out that there's all kinds of stuff from vaginal spasm to, premature ejaculation to hypoestrogenism to phimosis. There's all kinds of stuff. This is by no means a complete list, right? So there are actual doctors who will train for 4 years to become, OB-GYNs, so obstetrics and gynecology. And this is what they specialize in. So they they understand everything about gynecology, getting pregnant, the complications of pregnancy, birth control, all that kind of stuff. So I'm a psychiatrist. It's not actually my area of expertise. And so, determining what the right move is for you, involves, first of all, getting a good diagnostic evaluation if you're running into any of these problems. Second thing is to, make the right choice for you in terms of birth control and safe sexual habits and stuff like that, which is also highly individualized. I sort of mentioned ADHD. There are other things that are really important to know. So for example, birth control pills have a high, increase your risk of having stroke and ischemic problems, like ischemic strokes and things like that, and clots. So basically they make your blood more likely to clot. And so if you have a clot in a blood vessel in your brain, you're going to have a stroke. So a stroke is when a portion of your brain doesn't receive enough blood and then actually dies. So, birth control pills increase your risk of stroke. So they're not really recommended in people over 35. They are also compound with cigarette smoking. So if you smoke cigarettes and you're on birth control pills, they will drastically increase your risk of stroke. There are also other details which we kind of didn't go into here. For example, birth control pills tend to be dosed based in a particular weight range. So if you're outside of that weight range, the birth control may not be as effective, which means that your likelihood of getting pregnant could actually increase depending on your weight. So there are all these different medical complications, or not complications in terms of bad things, but the medical decision making is quite complicated, which is why y'all should go see a doctor about it. Okay? Yeah, so a lot of people are asking questions about non-heterosexuality and asexuality. We haven't talked about consent. We can definitely talk about those. I think it's a little bit beyond the scope of this lecture, which was designed to educate y'all about safe sex and what are the components of safe sex. Yeah, so okay, what do y'all want to talk? Do we have mods in chat? Let's do questions, or we can expand on let's figure out, what do y'all want to do? Do you guys want to do more questions? So let's pick. So I'll give you all a choice. First of all, we can look at subreddit posts. We can talk about some amount of tantra if you guys want to, and sexuality and spirituality. We can talk about asexuality, homosexuality, things like that. And so questions what are the questions? You guys need to give me a direction. So oral sex, yeah. So let's talk about oral sex. So just these are the topics that we can toss out, and if we can get a poll, that'd be great. Okay. So let's talk quickly about safe oral sex. So when it comes to non-vaginal penetrative sex, the risks are still there. They just get altered. So for example, if you look at vaginal sex, the risk of transmission from man to woman or woman to man are statistically somewhat different. When you look at oral sex, for example, the transmission risk of STIs is different depending on who's receiving the oral sex and who's giving the oral sex. There are devices called dental dams, which involve, so you can you do oral sex on someone with a condom, and that becomes pretty simple because it provides the same protection as a condom does in terms of penetrative sex. But for women, there are these devices called dental dams, which are essentially latex coverings for that you put over the female genitalia that allow you to perform oral sex, although there's still a barrier, right? So you can think about a dental dam a piece of latex, or even I almost think about it like saran wrap that you can kind of put over there, and so you can still get all of the pressure and sensation and things like that, but there's just there's latex or plastic between you and your partner. So there are devices like that. So, and then the transmission risk of in oral sex changes. So I'm a little bit rusty here, but if you kind of, so I think the transmission is greater for the person who is giving the oral sex than the person who is receiving the oral sex. Generally speaking, from men to for involving penises, that's the case. So the person who's giving the oral sex has a greater chance of contracting someone than the person who is receiving the oral sex. For women, I'm not sure. And then also when it comes to things like anal sex, the transmission risk, generally speaking, is higher. And so part of the reason for that is because, when you look at the female genitalia, it's designed to safely accommodate penetration, right? Whereas the anal cavity is not designed to accommodate that degree of penetration. And so what tends to happen is you'll get things like micro tears and stuff like that are more likely to happen. So being the recipient of anal sex, well, I don't even know what that phrase means, but, receiving, I'm trying to figure out how to say this medically. So I'm just, I can't, for some reason I'm having a brain fart. But basically, if you're getting fucked, then your chances of contracting a disease are greater. Okay? When it comes to anal sex. I just don't know how to say that medically. So, I'm trying to convey the information, but it's just because that's what happens. So especially if we're looking at things like HIV can be a blood-borne disease, right? So you can in the early days of HIV, people would get blood transfusions and they'd get infected with HIV. So when you're talking about anything that tears or causes damage to the epithelium, which is the skin or the surface, that's going to increase your risk of getting some kind of disease, because then the bacteria or the virus has easy access to, the bloodstream. The other flip side of this is that there is a lot of bacteria in the anal canal and in the GI system, which does not belong in the sexual organs. So, for example, there are even things like the fistulas or fissures, where you can sometimes, if you get kind of damage or infections or things like that, you can have a channel actually form between the GI tract and the urogenital tract. So the urogenital tract is like, the vagina, the urethra, things like that. And if you get a tract that forms like that, you get a lot of bad infections because the bacteria that live in your GI system do not belong inside the penis or inside the vagina. So another really simple tip about, sex in terms of anal sex that's safe is that like you don't, ideally you should use a condom, but you don't go from like anus to vagina. Like once you go to the anus, you don't go anywhere else until you like wash everything with soap and water. So just be careful that way. Okay. Yeah. So I mean, now really I'm struggling because I feel like this is just getting into meme heavy territory, but it's like still important information. Yeah. This is gonna get bad. There's a reason why I didn't include this in the lecture chat. Okay, so people are talking about asexuality and homosexuality. Okay, so that's what you guys want to talk about? That's totally fine. So I don't know exactly what to say about this stuff. So I think most of the, when it comes to homosexuality, like I think it's like everything that we said sort of applies, right? So except for the obvious things. So if you're like if you're a man in a homosexual relationship with another man, like I don't think anyone needs birth control, right? So there are like some obvious things which I would hope that you guys recognize doesn't apply. We just talked about oral sex and anal sex, which are important in terms of male homosexual relationships. We talked a little bit about dental dams and things like that in terms of female homosexual relationships. I think, obviously if you're a woman having sex with a woman, you also don't need birth control for the sake of like getting avoiding pregnancy. But all the information about STIs like still stands. Right. So like if you're having sex without a condom with your partner, then you need to get STI tested, whether you're gay, straight, like it doesn't matter. So that piece is universal in terms of the pregnancy risk and things like that. Like, that's sort of irrelevant in homosexual relationships. And then, in terms of some of the oral and anal stuff, like that becomes relevant depending on what you're doing and who you are. Yeah, so, okay. Now, in terms of asexuality, so this is going to be kind of, okay. Yeah, so saying that gay men can't get pregnant, I hope I don't get canceled for that, because I'm pretty sure that that's a statement of biology and not a statement of homophobia. So hopefully I'm okay with that. Like in terms of, I don't mean to offend anyone. I would hope that that's acceptable. Right. So when we're talking about trans, like then that changes. Right. So, okay. So let's talk a little bit about asexuality. So next thing is, so asexuality is like a little bit tricky because first of all, I don't know too much about it. And secondly, like the research on it is relatively new. So I've worked with a lot of people who identify as some version of asexual. And I know it sounds weird for me to say some version of asexual. And that's because it's been my experience that people are like heterogeneously asexual. So there are some sexualities where like they don't really feel lust, but they can enjoy and appreciate sexual activities that are like primarily emotional. So if there's like an intense emotional relationship, then like sex is actually fun and enjoyable for them. And these are people that have come into my office and identified as asexual at the beginning. And over the time of working with them, it turns out that they can enjoy sex, but even though they enjoy it, they don't necessarily like get horny or they don't feel lust. So that's one version. Some people just really don't have any enjoyment of it and don't feel any desire to do it. So I don't know too much about the research on that because I think a lot of that research is relatively new. So then let's kind of think a little bit about asexuality in terms of, so I'm going to kind of think out loud. So let's think about asexuality in terms of like, what are the causes of asexuality? So like, let's think about the hypotheses, right? So one is that it's a normal sexual variant. So we understand that like now that human psychology has like sexual variation. So not everyone is hetero. So it's just possible that some people, for whatever reason, are just like, it's a normal sexual variant. It's not a disease in any way. It's not pathological in any way. It's not a problem that needs to be fixed. It's just some people are like that. Now, why are they like that? We're not sure. The second thing to think a little bit about is that there may be some kind of pathologic contribution to it. So we do know, for example, that people who are sexually abused or traumatized, that sexual abuse or trauma alters for some people their relationship to sex, which makes perfect sense, right? So if you have some kind of sexual experience that is traumatic, or you have many experiences that are traumatic, it's going to alter the way that you perceive the thing. So this is not true of just sex. It's like a basic attribute of human psychology. It's like, if every time I see a dog, I get bit by a dog, it's going to alter the way that I relate to and perceive dogs. So there have been cases of patients that I've had where part of their asexuality seems to have a trauma contributor. And what that sort of means is that as we work through the trauma, their relationship to sex can change over time and become more positive. I hesitate to make any kind of judgment on that, because that may imply to some people that, asexuality is a consequence of pathology or is an illness that can be fixed. Whereas I don't think I have data to support that conclusion by any means. What I've just noticed is that in the population of people who are asexual, there is a variety of different presentations that have a variety of different contributions. And as a result, sometimes trauma is a piece of asexuality, which sort of makes sense in terms. But in that sense, I would say that the asexuality is not an attribute of the person; it's actually more a consequence of the trauma. So, very simply put, I've had a couple of patients, not too many, who just had bad sexual experiences, and as a result, almost as a defensive mechanism, they have squashed any kind of sexual desire that they've experienced, like almost subconsciously, in a sense, like intentionally, but it tends to be usually subconscious. But I don't, I've also worked with people who are asexual who don't have any kind of indication of trauma, so it could just be a normal variant, right? We also know that historically there have been some professions or situations that have been leaning away from sex. And I say leaning away from sex because we don't really know if we look at people like priests and stuff like that, we actually don't know historically how much they leaned away from sex. Like, that may have been the doctrine, that may have been the, what people said they were supposed to do. But if anything, we've learned that, what they say they're supposed to do and what they actually do can be different. So we don't really know. Is there a pathologic contribution? In some cases, yes. Is it a normal variant? It's looking like that. Especially because, I have worked with that subset of people who, for them, their sexuality is heavily driven by emotions as opposed to lust. So that just seems like a different kind of variant to me, like in terms of what turns them on, right? So like we talked a little bit about BDSM and fetishism and stuff like that. So we just know that there are fluctuations or variants within the brains of people that cause them to be attracted to particular things. There's also, I want to say, disagreement within the psychological or psychiatric community. Maybe disagreement isn't the right word. Maybe a lack of consensus is the better way to phrase it, because I think that it's an emerging area where we just haven't done that much research. So, for example, if you go back to Freud, like Freud believed that a lot of our sexual drives, or even arguably all of our sexual drives, were somehow shaped by early lifehood experiences. So one of the theories that he came up with is that there was like 3 phases of child psychology: the anal phase, the oral phase, and the phallic phase. And there's clearly a lot, and there was a lot of sexuality tied up into those kinds of things and power struggles. And he related a lot of stuff. He talked about the Oedipal complex and other things like that. So we just, in the field of psychology and psychiatry, I don't think we have clear answers yet. So I'm sure there are a lot of people out there who are more qualified than I am, who do this work a lot more than I am, who have better opinions than I do, or more informed opinions. But in my experience, essentially, like, asexuality has a variance of like different presentations. So the first is as a normal variant of sexual preferences. And that too gets divided into 2 pieces. One is that people can be like more emotional as opposed to lustful. And so their ability to enjoy sex has more to do with like the emotional connection, or like the oxytocin stuff. And the second is people who just really have no degree of lust or enjoyment through sexual activity, and they're just kind of like neutral towards it. There are people for whom the asexuality, in my experience, is related to something psychological or traumatic. In the case of sexual abuse, sometimes it's almost like a protective mechanism. I've also noticed in some people, I'm not 100% sure about this, but I have hypotheses with some people that I've worked with, that part of their asexuality is like almost a, how can I say this? It's like a protective mechanism against fear of rejection. So we see this a lot. There's a psychological defense mechanism called reaction formation that sometimes causes people to denigrate that which maybe a reaction formation isn't the right way to think about it. But so for some people, I suspect this, I don't really know. I haven't gotten to that point with them. But I suspect that some people are afraid of their sexuality because they may be afraid that they can't act it out or capitalize on it or fulfill those desires. So they go through the active process of like suppressing their desires. Like, and it's almost like if I fear that I'm going to be alone for the rest of my life, then I'm going to start identifying as like asexual. And so that's the kind of thing that, like, you know, it's kind of a damning thing to say from a position of authority, but to be completely honest with y'all, like, I've made that observation. I don't know if it's actually correct or not. And it certainly happens with other parts of life, right? It's like a basic aspect of human psychology that transcends sexuality. A good example of this is, you know, I had some friends that love to poop on Ivy League institutions. And the more that I talked to them, the more that I got to know them, I realized that, like, the reason they poop on Ivy League institutions is because they don't think that they're ever going to get in, and they feel like other people there are smarter. They're not smart, or other people there aren't actually smarter than they are, but they won't ever get in. So what you start to do is devalue the things that you can't get. So we'll also talk about, you know, like I've worked with people who will, you know, call people who have jobs like corporate peons because, like, there's actually some degree of like envy there. And so they're like, oh, all these, like, I see this also in the realm of spirituality, like false spirituality, where it's like all the people who are like, I can't cut it in the real world and I can't hold a job. So what I'm going to call myself is amaterialistic. And all those peons are materialistic and I'm a spiritual. That's what the reason I know that one is because I was that way for a while, right? I was like, oh, like, I'm going to be better than all these people who like want to have successful careers. I'm going to rise above it. There's a lot of ego and stuff like that. I have seen notes of that in terms of asexuality, that asexuality can almost be a defense mechanism for people who are afraid that they're not going to be able to get into a sexual relationship, right? So if I can't have something, one of the fastest ways that I can be internally at peace with that loss is to convince myself that I don't want it. And so I don't mean to label people who are asexual that way, because like I mentioned before, it could just be a normal variant. But like most things in psychiatry, like, it's honestly multifactorial and it doesn't come down to one thing. If you were to ask me, why are people depressed? You know, like, it's not going to come down to one thing. It's not just because they're mentally ill. There's more to it than that. And the last thing in terms of the differential diagnosis of asexuality is actually physiologic stuff. So, for example, if we look at, sexual drives and behaviors, they tend to be physiologically mediated. So low testosterone, altering amounts of estrogen. Like, for example, if you want to see, the most asexual people on the planet, go to like a terminal cancer ward. No one feels like having sex at all, anytime. They have like no sexual drive whatsoever. But that has nothing to do with trauma. It has nothing to do with internal fears of blah, 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 yada, yada, yada. It's not even a normal variant. It's a physiologic consequence of illness. So we do know that sexual drive tends to be correlated with different hormonal levels. There are some weak studies, there may be better studies, the ones that I've read are weak, that even correlate female libido with their testosterone level. So women with high levels of testosterone seem to have higher levels of libido. So we know that there are physiologic contributions of libido. So it's possible that people who are asexual will have some kind of hormonal contribution to their sexual drive. We know that scientifically that happens. Is that sufficient? Sorry, that was kind of off the fly, so it may have been disorganized. Libido is a term that encapsulates sexual drive. Are nocturnal emissions normal and can they be stopped? Yes, nocturnal emissions are normal. So for people who don't know, nocturnal emissions are like sometimes you'll have some degree of, semen or seminal fluid that comes out of the penis while you sleep at night. Sometimes they happen in conjunction with sexual dreams. They are normal, and they generally speaking stop when you become sexually active or masturbate. So someone's asking, do a lot of our kinks or fetishes we have come from trauma? I would say no. So when you say a lot, I don't know how to quantify that. But in my experience, and there is evidence to this, we did a lecture on BDSM, that sexual variation appears to be a normal, it seems to be a normal variation within the population that is not necessarily tied to trauma. Now, sometimes sexual kinks and things like that can be tied to trauma. That's what makes things so damn confusing. So there's also things like, another good example of this is like, so a lot of people will believe that gender identity is tied to trauma. And that gets very complicated because we do know that there's something called gender identity disorder or gender identity dysphoria, which can sometimes have a history of trauma. But that is like that's sort of the pathologic version of gender identity is tied to trauma. It's unclear whether a non-pathologic version of gender identity is tied to trauma or not. Does that make sense to people? So there is a diagnosis, which is a pathologic diagnosis, which means that gender identity leads to an impairment of function. So when the gender identity confusion or gender identity issues are so bad that they lead to impairment of function, that appears to be correlated to trauma, but not the gender identity itself, if that makes sense. So that hopefully people, I explained that. So someone was asking, what does pathologic mean? That means that by definition, their experience of gender identity impairs their function in some way. Right? So this is where we have to be really careful, because what a lot of people will do is interpret that as saying that gender identity is due to trauma. Whereas I don't think you can make that determination. I mean, could it be? It's possible, but I don't think that's what the evidence actually demonstrates at this point. Because the studies on gender identity disorder are talking about a subset. There's a huge selection bias. These are the people with gender identity dysphoria. So their gender identity is causing them problems. So we're taking a group of people that are by definition impaired or suffering profoundly in some way, and we're linking that subset to trauma, which sort of makes sense, right? So I think any kind of psychiatric illness in that way is going to have a correlation with trauma. Oh yes, a lot of questions about No Nut November. So hopefully we'll have something. I think we're going to try to do another lecture on that, but we're going to really dig into the research. So someone's asking about, what about the stigma surrounding herpes and how common it actually is? So there's a stigma around herpes for sure, and it happens to be quite common. So I think this is where the more you get educated, the better off you're going to be. And I think this is where having a conversation with your partner is really important, right? So the foundation of a good sexual relationship is trust and safety. So, even if you have herpes, I think that's okay. You can even, because the 25 to 40% of the population, if memory serves, has it. I've seen different studies that cite different levels. And so I think it's just having a conversation about, how are we going to handle this problem? And so there are, for example, suppressive treatments for herpes. So you can take medication, you can take antiviral medication every single day, and that reduces your risk of transmission quite a bit. So for some couples, that's the right move. For other people, it's sort of you can test positive for herpes but never have symptoms. And so you can have a conversation about, okay, what's the risk that you're going to get, the transmission is going to happen. For some couples, what they'll do is Like you'll actually get, sometimes you'll get like swelling of lymph nodes and things like that ahead of the actual outbreak. So for some couples, like they can kind of tell like, okay, there's an outbreak coming. So like they'll start medication right around the time of an outbreak. So there are all kinds of like, different strategies. And I think the main thing is just to have a conversation with your partner about it. And this is where it's really, really hard, because if you do have, like if you're HIV positive or you have herpes and you want to have a relationship with someone, having a conversation with them could be incredibly rejecting, which I think is sort of fair, right? So part of the process of trust and safety and consent is that if your partner doesn't want to be with you because there's a risk of, a transmission of an infection that they're going to have to live with for the rest of their life, that's the opportunity to reject you that they deserve, right? So, and it can be hurtful for you. Absolutely. It can suck for you. But I still think that if you really want to have a successful, healthy, long-term relationship, you have to give them the option to reject you. Because what you're also doing is give them the option to accept you. And what I've seen is far more toxic is when you take that decision away from them, you assume you can manage it, and then they get an outbreak, and then it like blows up in your face. Because then they're like confused. They're like, where did this come from? Issues of infidelity arise. They're like, have you been sleeping around? Like, there's all kinds of problems that can happen. So, generally speaking, and this is where I've tried to steer clear of like my personal values in terms of relationships, but generally speaking, I advocate for transparency and openness in relationships, because I think that's when I see successful ones. Okay. Why the hell does school fail to teach what you're teaching in the stream makes my blood boil? I don't know. So like, I think, we were thinking about this at Healthy Gamer. We're like, what are we here for? Like, what are we doing here, chat? Like, why are we here? And I was kind of thinking like, because a lot of people will ask us like, oh, well, are you going to do this? Are you going to do this? Like, how do we decide what to do? And the short answer is like, I think what we're here for is to educate y'all on all the things that no one else has educated y'all about. And that's really what I see is our contribution. So when I think about like what my dharma or duty is and what my karma is like, I grew up with a lot of advantages, right? So I'm the son of 2 physicians, and I got to spend 7 years training to become a monk in India. And then I got to go to medical school and became a psychiatrist and trained at a really nice institution where there are a lot of very, very good teachers. And so I think like my job is to just spread whatever knowledge that I've learned to y'all, if you want it. And y'all tell me what you want. That's our goal. So I do think that, so there's an interesting study. I'm going to try to, damn it. There we go. I'm going to try to find this citation, but there's an interesting study that showed that, I think it is a study on 15,000 students. They gave half of them social and emotional skills training. And what does that mean? That means that they taught half of them like how to recognize their emotions and like how to socialize, like a class, like, like mathematics, history, how to talk to other humans, how to recognize your emotions. And it turns out that the half of the students who received that training had a GPA increase on average of 1.1. So their grades were 11% higher. So it's like worth an entire letter grade, if I remember. And so that's like staggering, right? So like what that means is like one group of people, and you're like, how can teaching me about my emotions help like increase like my math score by 11%? And the short answer is like, think about all the things that lead to success in math class, right? It's like, if you're sick, do you know how to ask for notes? Do you have a study group? Do you have a group, like, do you know how to interact in a group project? There are so many aspects of like social and emotional skills, like do you procrastinate before a test, that correlate with with actual real world success. This is the big hypothesis that we've got. So we've seen some really interesting, we've had 10,000 people go through the coaching program, by the way. And so we were looking at that data. Hopefully it'll be published at some point in the next 6 months, peer reviewed and all that good stuff. But we were looking at that and we were trying to figure out, like, our coaching program's like pretty damn good. Like, why? Like, what's actually happening? Because we see improvements in depression, we see improvements in anxiety, but we're not actually like treating depression or anxiety. Like, what's actually going on? What's the mechanism through which people are getting 20, 30, 40% reductions in depression? Because we're not clinicians, right? So we're not like actually giving mental health treatment. And our running hypothesis is that really what our program does is increases like social and emotional skills. So your ability to recognize yourself, gain awareness as to like what causes you to tick, what drives your behavior, that in turn is going to affect your relationships, and that people start to like feel better. They feel less anxious, they feel less depressed, they feel more in control of their life. So we're not really sure, but we're looking into it. Hopefully we'll have something for you all soon. Oh, HPV. So real quick, so HPV is human papilloma virus. Very concerning, especially because it tends to lead to cervical cancer. Definitely a good example of successful vaccination, by the way. So like, since we've implemented HPV vaccines, I think the rate of cervical cancer has gone down by like 89%. So we've like eliminated 90% of the cervical cancer by HPV vaccines. So you should, I'd recommend, I don't know what the current guidelines are, but I think HPV vaccines have become available, especially for women. I think men can maybe get vaccinated too, but are really important for women, or girls. Like, you can get vaccinated around 11 or 13, I think. So it's just good to get. So it's HPV. So some viruses, I don't know if people know this, but some viruses can cause cell replication. So a good example of this is like a wart. A wart is actually like a slow growing virus in most cases. And so like it causes like a growth of like keratin and skin. And the reason that viruses cause growth is because a virus doesn't have any machinery itself for reproduction. So what happens is a virus goes into a cell, tells the cell to turn on all of its replication machinery, and as a result, the cell divides and grows. And then when all the replication machinery is on, it also replicates the virus. So it's kind of like, the virus comes into your house and is like, doesn't have a kitchen, but it's got groceries. And it's like, oh, why don't you fire up the stove and turn on the oven and stuff like that? And then once all the devices are turned on, the virus starts cooking its food. And as a result, you're cooking your food, it's cooking its food. So it causes cell growth and replication, which can sometimes lead to cancer, because all cancer is cell growth out and replication that's left unchecked. Also not an expert in HPV, so y'all got to be careful there. I hope I'm not disseminating incorrect information. No, it doesn't mean that any virus can lead to cancer. So for example, like influenza does not, as far as I know, increase your risk of cancer. So there are some viruses that are more carcinogenic, essentially, right? So and the mechanism of action is also different. So for example, HIV can lead to cancer, but the reason that HIV leads to cancer, the mechanism that HIV leads to cancer is different. So generally speaking, when our body develops cancer, we kill it. So a lot of people, this is kind of scary, but we have a lot of pre-cancer cells or even small cancers that develop that our body just recognizes, our immune system recognizes it, attacks it, and kills it off before it gets out of control. What happens with HIV is we get a bizarre series of cancers that are very, very rare in humans. And the reason is because HIV knocks out our immune system ability to kill the cancer. So that's why we get rare cancers in AIDS, actually, not just HIV. So, yeah. So some viruses can increase your risk of cancer, for sure. But the mechanism is like dependent on the virus. And once again, y'all, I'm a psychiatrist, right? So this is not my area of expertise. So we got to get an immunologist on here, or like an ID specialist. Okay, Tantra. Let's talk about Tantra real quick. So can you get STDs or STIs from solo pleasure? No. So the definition of an STD or STI is sexually transmitted infection or disease, right? So there's no transmission. Seriously, like it's a good question. Like, these are why we have these streams. You guys with me? Like, it's a good question. Like, that's why we're here. Like, is it a little bit silly? Sure, but like that's what we're here for. Right? Because this is what I'm saying. Like, these, you can just ask. Yeah. It's a good analogy. PvP versus PvE, basically. Right? So can virgins get STDs or STIs? Generally speaking, I want to say no. Right? So that also depends on what your definition of a virgin is. But remember that STD or STI, once again, involves transmission. Right? So it's like from one person to another. So by definition, these things like chlamydia and gonorrhea, like, I think there was some fear, for example, that like HIV or whatever can be transmitted through toilet seats and stuff like that. Generally speaking, I don't think about that as a big source of transmission. It may have happened. There may be case reports about it. But generally speaking, like, those are the diseases that get transmitted. Like, the virus has evolved to infect like those parts of our body. So I don't know if you guys know this, but viruses will have these proteins on their surface which target particular receptors on cells. But not all cells have the same kind of receptor. So a really fascinating example of this is, normally the foreskin of the penis is full of immunoprotective cells. So it's got like a bunch of immune cells because we've evolved to have like, because we know that there are STIs and STDs. So the human body is evolved to like, man those walls with tons of soldiers. Right? So like that's where we've got a very high concentration of T cells. So that if we get an STI, like we've got, we're putting all of our defenses there. So the interesting thing is that if you look at people who are circumcised and don't have the foreskin, they actually have a slight resistance to HIV. And why is that? It's because, remember, the cells that HIV can target are immune cells. So people who have foreskins may actually be more vulnerable to HIV because that's where we have the most soldiers, but soldiers are food for HIV. So it actually makes like transmission of HIV potentially riskier if you have a foreskin. But foreskin protects you against like all of the other STIs. So now we're really getting into video game-esque balancing, okay? That's what evolution is. It's like, we're going to give you plus 10% STI resistance, but minus 20% HIV resistance. And circumcision actually like reverses it, right? So how do you want to build your character? Like, what kind of biological advantages do you want? I'm serious. It's like fascinating. Right? So it's like HIV, like that's how evolution works. When something is OP, like foreskin is OP, right? And then like along comes a virus due to evolution that targets the very thing. So it's almost like an evolving meta within a video game. So it's that's how evolution works. Like that, there's a reason why we use the phrase evolving meta, right? The meta evolves just like the human body does. Generally speaking, I do not medically recommend circumcision. So I know it's like a charged topic. I know that there are a lot of cultural and religious like reasons, right? So one thing that I've tried to steer clear of, let me know if I did a bad job or if, like if someone wants to criticize me for espousing a kind of value or so one thing I tried very hard to do is like try to be like medical and not espouse a particular value system. Like I'm not saying that, I'm not commenting about abstinence or abortion or anything like that or getting circumcised or uncircumcised. All I'm saying is from a medical perspective, I don't think that circumcision is like offers a clear medical benefit based on my understanding of the literature. There may be doctors out there who know more than I do and disagree with me. So yeah, so like right, so like if we're trying to figure out the stats of a condom, so condoms offer like 99% STI resistance, but result in a pleasure debuff of about 20%. And then also have require you have to do a check to put one on properly, right? So you have to do like some combination of like an int check and a dex check with DC5. And if you fail that check, then you don't get the benefit of the condom. Right? It's like I put on my condom, DC check, dex check DC5. Actually, probably dex check DC1 or 2. Right? And then when we talk about that 1%, the 5% or 10% failure of condoms, that's like the critical fail. Like you rolled a 1. GG. So DC5 is a difficulty class, I think. I don't know what the C stands for. But in Dungeons and Dragons, you have a 20-sided dice, and then if a task is hard, you have to roll higher than a particular number. So like the lower the DC is, the easier the task is to complete. So difficult tasks may be like DC 20 or DC 25. Easy tasks are like DC 5. So Sherbet Aurora is saying, my parents didn't use protection, rolled a 1, and now I'm here on twitch.tv. Welcome. I think you're not the only one. Someone's asking, do you repost all your VODs on YouTube? Because this is so informative and I feel like I'll need to watch this later. Yeah, I mean, we try to post most of our VODs. Not everything gets posted, and that has something to do with just how the channel uploads stuff works. So, but yeah, we try to post most of it. Oh, this is such a good question. So how did the first STI come around if they can only be transmitted from someone who has one? What a fantastic question. So, great question. Does anybody know the answer? Such a good question. Okay, you guys ready for this? So, it's not monkey's fuck. Okay, so remember, herpes simplex has 2 versions, right? There's 80% of the population has the oral version of herpes simplex. 25 to 40% of the population has the genital version of herpes simplex. So what happened, where STIs came from is someone with oral herpes decided to suck a dick, right? And then some of the virus mutated and could actually infect and replicate in genital tissue. Right? Probably what happened. Seriously. That's what happens. So if you look at COVID, right? So some people hypothesize that COVID is a zoonotic transmission. So it was a virus that was infective in a species that was not ours and then evolved. So one tiny amount of virus evolved to be able to infect human tissue. That's part of the reason it's so damaging, is because the virus is so foreign to us that our body is not evolved to fight against this kind of coronavirus. And so like it like tears through the population, which is probably what happened with herpes too. It's like there's a reason why it's so prominent. It's probably a combination of high infectivity as well as like going dormant for times so that like, you know, it doesn't actually kill the people off. So if someone is appropriately saying it may not have been a BJ, it could have been cunnilingus, that is correct. You are correct. So this is kind of a random question. Do you have any thoughts on whether CRISPR could help solve mental health issues with gene modification? So for those of you who don't know, CRISPR is a technology that allows you to splice out particular genes and insert other ones instead, or alleles, I should say. And the short answer is like not anytime soon. So remember that CRISPR is very effective when there is like a clear gene that is contributing, that is the sole, not sole, but a major contributor to a problem, right? So like CRISPR, I think is like effective for cases like cystic fibrosis, I think. So once again, psychiatrist, okay? So I'm relying on like years of basic medical knowledge, like years ago studying like basic medicine and understanding these things. But so for something like cystic fibrosis, where you've got like a particular allele that's mutated, right? Or a gene that has an allele that's mutated. And that single mutation is essentially responsible for the constellation of problems that you get. So then it's very effective. The problem is that most mental illness does not seem to have a single gene that you can replace to fix it. So mental illness does not get isolated down to a single gene. So there are studies that show that there are clearly genetic correlations to mental illness, and irritability scores can be quite high. So for example, ADHD has a 70% concordance between twins. So it does seem clearly that there's a genetic influence, but I don't know that we've like figured out like there's an ADHD gene. I don't think that's how it works. I don't think there's a autism gene. There's not a depression gene or a anxiety gene. So you can't just go and replace one gene. So chances are that mental illness is due to a lot of different genes that are doing a lot of different things, right? Because remember that the cystic fibrosis gene is a chloride transporter, and there are chloride transporters like all over the body. Like every cell, I think, maybe not every cell, but most cell, like certainly like, you know, action potentials and stuff are going to have to do with chloride. Like a lot of cells are going to have chloride transporters. So even changing one piece of machinery can result in a set of symptoms where like you make a bunch of mucus and you can't clear it out. Like it's just a chloride transporter, right? So I don't know that we've found a mechanism to most mental illness, because most mental illness is like a complex emergent phenomenon. So I don't know that CRISPR would be able to help very much. Okay. Jesus, it's so late. What age would you recommend watching this stream or VOD? Okay. So like a lot of the stuff in the stream or VOD was intended to be for people 13 and up, but I think especially some of the humor elements and even some of my responses, you know, because this is Twitch, are really more appropriate for 18 and older. So I'd say that like 18 and older is who should watch this. And if you have if you're 13, between 13 and 18 and you're a parent should watch it first and make sure they're okay with their kid watching it. That's what I would recommend. Does that make sense? So this stream is supposed to be for people, mature audiences, chat. Right? If you're a 13-year-old parent, that gets complicated, right? Because like teenage parents get emancipated in many ways, and it's like unclear like what happens with them. I don't know. If you're a teenage parent, I don't know what to do. It's it's a bug. It's something that we did not account for in our when we were coding this lecture. It's like a bizarre feature of the game. I mean, I think for the most part, especially like the first half, like a lot of that stuff is like, I mean, I will have those conversations with like 16-year-olds about the nature of like sexual health and safety. Some of the jokes are kind of crass, let's be honest. Okay. You guys want to do a Muladhara Chakra meditation? Let me think about that. So someone's asking, is hentai bad for the brain? I actually don't know. I'm not sure, man. I think that, a lot of pornography use or any kind of high dopaminergic activity for an extended period of time is probably bad for your brain. But specifically hentai, like I don't know the research on hentai versus pornography. I don't know. We can look into it. Are there any questions you're sick of answering? Yeah, all the questions I'm sick of answering are the ones I don't answer. Right? Because I get to pick. Okay, Tantra meditation. Sure, we can talk about Tantra for a second. We can do a Tantric meditation. Okay, let me just think about what kind of Tantra meditation to do. So is Tantra meditation okay for PTSD? So here's the main recommendation that I have for people with PTSD. I say do open awareness meditations with a lot of caution. So remember that, so there are evidence-based studies, so there's studies that look at types of they don't actually look at types of mindfulness, but so if you look at, for example, dialectical behavioral therapy, DBT has a lot of mindfulness techniques in it. DBT is also effective for people with borderline personality disorder and trauma. But if you look at the kinds of mindfulness techniques that they tend to do grounding techniques as opposed to open awareness techniques. So in my experience, and this is all in Dr. K's guide if you guys haven't watched this, but so in my experience as a psychiatrist, like in the case of trauma, your mind has put up walls to keep certain things outside of your conscious mind. So when you have an open awareness meditation where you're kind of non-judgmentally letting anything in, it can actually like unlock that trauma and can be difficult. Whereas what tends to happen when someone is like in a flashback state, right? So when I am on call and stuff, sometimes I'll have like someone with PTSD who's like in the middle of a flashback. And when I intervene with them, I'll walk into the room and I'll say, hey, I can see you're struggling right now. I'd like to try to help you. If you want, we can offer you medication. If you don't want medication, we can give you a weighted blanket. And if you're open to it, like maybe we can try some meditation. And in those situations, the kind of meditation that I'm going to, like if they're re-experiencing, let's say like losing their limb, I'm not going to tell them to sit down and close your eyes and observe the thoughts non-judgmentally that float through your mind. Like, just like notice, oh, like there's that memory of me losing the limb. Like that's not going to work. In fact, what you need is a grounding meditation. So something that your mind can focus on to push away all the other thoughts. So that's what I would recommend. So tantric meditation is a different axis. And we actually now released like a meditation index where you can search based on like different boxes. So you can pick do you want to look at tantric techniques? Do you want to look at grounding techniques? You can check tantric and grounding, and that'll give you like a set of techniques, or you can check open awareness and tantric, and that'll give you different techniques. So you guys understand that tantric and like in grounding versus open awareness are like different categories. So it's not that tantric meditation is good or bad for trauma, right? There are going to be some kinds of tantric meditation which I would use in trauma. So for example, Manipura chakra techniques, which are tantric in nature, some of them, will be like theoretically effective. There have no trials been done on that, right? So people haven't studied that formally. But in my clinical experience, it seems to work. So Tantra isn't diagnosis specific. The system is different. It's kind of like asking like, is a particular video game good for anxiety? And it's like, that's not, there may be video games that are okay for anxiety, but the buckets are different. Okay, so let's talk. Tantra is basically sex with emotions being more important than physical stuff. I don't think so, but that's not my experience. So let's just talk for a second about Tantra. So the goal of... So Tantra is like literally translated as technique. So a lot of tantric meditation is like closer to, for lack of a better term, magic. So I think the best Western description, or the best Western word that captures like Tantra is actually magic. So Tantra has this belief, and this is also all in the guide, that there's like a cosmic energy that can be cultivated through particular kinds of practices. And so Tantra is broken into three branches. One is mantra, which is the like syllables or like words of power. Like that's what a mantra truly is, right? So Om is a mantra. And through chanting Om, you will cultivate a particular kind of spiritual energy. The second thing is that there are yantras, which are like symbols of power. So they're like yantras which are drawn, which are supposed to cultivate or capture some kind of shakti or energy. And then the third is yagna. So yagna are like rituals, like sacrifices and things like that, which will once again cultivate a particular kind of energy. So I think one of the things that you guys have to be really careful about is that there's a lot of sterilization of meditative tradition going on right now. I use this word with some caution, but I think there's a lot of cultural appropriation basically going on, where like people are taking traditions of meditation and the parts that are not culturally acceptable, they're just kind of removing it from it, right? So they're just sort of like, yeah, that doesn't exist anymore. But if you really look at the roots of what Tantra is, like that's the roots of Tantra. Like it's those three practices. And so that's really what Tantra is. So in terms of like tantric sexual practices, so this is another example of like things that kind of got confused and stuff, but are not confused. People learn tantric sex. It's an interesting technique. So the goal of tantric sex is the goal of some meditation techniques, or most meditation techniques, is to attain a particular state of consciousness. So what is tantric sex? Because what people sort of realized is that like the moment of orgasm is a state of mind that is free of thought. So like you may have thoughts before the orgasm and you may have thoughts after the orgasm, but during that actual period of orgasm, it's like a no mind state. Okay? And so what tantric sex, and so the goal of meditation is to attain a no mind state. So what some people sort of realized, they looked at it very like analytically, and they're like, what are the tools that we can use to help ourselves get into a no mind state? So they came up with chanting, for example. So they said, okay, if I chant things over and over and over again, at the beginning I have 10 thoughts in my head, and if I start chanting Om will replace one of the thoughts. I'll have an Om, and then I'll have 9 other thoughts, and then I chant it again, and then I'll have Om and 8 other thoughts. And if I chant for a while, the Oms will knock out all of the other stuff. And then if I keep chanting Om, my mind will acclimatize to the sound of the Om or the feeling of the Om, and I'll even lose the Om. It'll become somewhat automatic, and I'll be left in a no-mind state. This is dhyana. Okay? Then what people realize is, oh, like that's kind of interesting because there's also this like physiologic thing called orgasm, and if I really pay attention to what happens there, it kind of obliterates most of the thoughts in my head. So then what happened is like the yogis sort of like were like, okay, we wonder if we can use this as a tool of meditation. And so then they developed techniques of tantric sex. And the technique of tantric sex essentially involves a prolonged orgasm. So like you can have an orgasm for 5 minutes, 10 minutes, half an hour, an hour. And so the goal is to stretch that orgasm out for a long period of time so that you can maintain the no mind state of bliss. So remember that like when people talk about samadhi, so samadhi is like temporary enlightenment, they use the word bliss, right? And so like there's a correlation between the no mind state and experience of bliss. So then what, so like, it's a totally legit, like from a meditative standpoint, it's not even about the sex. It's just a powerful tool to enter the no mind state. Then what happened is like some tantric guru taught it to some person, who's from the West, basically. Could be a little bit racist for me to say that, but I think that's literally what happened. And then like the person was like, wow, I can have an orgasm for half an hour. That's so cool. And then they came over here and they started like talking about it and teaching it to a bunch of people. And then everyone really enjoyed it for the pleasure. So you can use the technique for the pleasure, but that's not really ever what it was designed for. It's not to induce pleasure. It's to be a tool to get into the no mind state. And then everyone got into tantric sex. And then the problem is that it's actually very difficult to do and requires a high degree of like meditative training. And so now people just talk about it, but there really aren't good teachers of it. The other thing that's kind of interesting is traditionally, like the tantric sex you were initiated into it by a guru. So that too is something that, I think probably on balance a good thing. And we've steered clear of, right? Because like the guru-disciple sexual relationship is rife for abuse. So we've steered clear of that. So now let's think about what kind of, it's problematic, right? And someone's saying, and that's why it's sterilized. Yeah. So I think that the sterilization offers some degree of large-scale public health protection at the cost of like some of the most powerful techniques. So what we're doing is making meditation teaching that's not even a word. We're making meditation instruction safe. So we're increasing the safety, and what we're reducing our ceiling in terms of what meditation is capable of. Okay. I just have to think about what we're going to teach you, chat. Yeah. The kinjutsus, right? So I'm not going to teach you guys 30-minute tantric sex. So that, like I said, it requires a lot of practice, and you have to be able to, it's we're not going to do that. Sorry, chat. Why not? Because I'll teach you meditation. I'll teach you levitation before I teach that one. Because it's not meant to be taught like that, right? So it's like, it's a spiritual technique. It's not meant for Twitch chat to have 30-minute orgasms. Let's just think about what's a good tantric technique to learn. I'm drawing a blank. Okay. Okay, let me see if I can find this. I wonder if I can find... Yeah, so we can do Muladhara Yantra. We'll do Muladhara Yantra meditation. Okay, if you guys want to learn. Okay, so I'm going to just Google this thing. Okay, so what we're going to do is a Muladhara Yantra meditation. So this is going to be sort of based on Trataka. So if you guys remember, if you all have seen Dr. K's guide, you know that there's a fixed point gazing this seems too bright. Let's do this one. This one seems better. So Trataka is something called fixed point gazing. And generally speaking, what you do is you look at a yantra, you stare at a yantra for some amount of time without closing your eyes. In this case, you can close your eyes, so we're not going to do true Trataka, but if y'all are familiar with Trataka and you've done Trataka and you've practiced Trataka, you can do Trataka on this yantra, and that will increase the potency of the meditation practice. Case in point, if you guys haven't learned Trataka and can't do Trataka, there's no way you're ready for the tantric stuff. So what we're going to do, I'm going to show you guys this. So this is a Muladhara yantra. So yantra is a symbol of power, and this is the yantra, or a yantra, for the Muladhara chakra. So you guys may notice that there's I think this is Lam, which is the mantra for the Muladhara chakra. There's a Lingam, which is there's this thing called the Shivling, which is sort of like a phallus. It's kind of like that on purpose. And so it sort of represents like creative energy. And the animal for a Muladhara yantra is an elephant, but I don't know if it's got a bunch of tusks or what. It may have 1, 2, 3. Yeah, it's got seven snouts. So if you guys want to do like a tantric practice on the Muladhara chakra, so the Muladhara chakra is the chakra that governs like sexual energy and base desires. I do Muladhara techniques. I teach Muladhara techniques to people with addictions to help them like get control of their more basal desires. So what we're going to do is just take some time to like stare at this. So we'll stare at it for 30 seconds. And then we're going to close our eyes and kind of see the after image of it for 30 seconds. We're going to open our eyes for 30 seconds, close our eyes for 30 seconds. We'll do that for a period of 3 minutes. Okay? So I want y'all to sit up straight and make sure your back is straight, neck is straight. Go ahead and take a look at the yantra. So take a deep breath and exhale, and slowly let your eyes relax. Let your eyes unfocus and take in the attributes of the yantra. Notice that there are 4 petals, a circle, the colors, the square, in the middle a triangle, the shapes. And now close your eyes. And now in the Chidakash, or the screen of your mind, notice that you can almost see the afterimage of pieces of the yantra. You may be able to see the petals, the ring in the middle. You can also visualize the pieces of the yantra. Visualize the petals, the circle, the square, the triangle, the lingam inside, the lum above, and the elephant below. And now we'll open our eyes again and stare for about 30 seconds. Try your best not to blink. Unfocus your eyes. Take in the whole image. Now deep breath in, and as you exhale, close your eyes and see the afterimage. It may be hard to hold on to, but let it float to the surface. If you're able to see it, you can continue focusing on it. Otherwise, you can even draw it in your mind, visualize it. Deep breath in and out. And now open your eyes for the third time. 30 seconds, unfocus your eyes, take in the whole image. If it's hard to unfocus, you can also focus on a particular part and just stare at that. The lingam in the middle, the elephant, the character Lum. Let your eyes relax. Try not to blink. You can enter into a half-lidded gaze. And now close your eyes. We'll continue for about a minute. Now go ahead and let yourself come back. Notice the sensations of your body. Oh my God, I'm so tired. Oh man. Let yourself slouch. Let yourself breathe. We've come back to this world. Yeah, so for those of you that are saying I failed to see the picture, that's actually okay. So I set y'all up to fail a little bit. I mean, not on purpose, but remember that if you really want to see a good image in the Chidakash of your mind, in the screen of your mind, you need to gaze at it for longer. So if you can stare at it for 60 seconds or 90 seconds, your photoreceptors in your eyes will exhaust, and then you'll see the negative image after you close your eyes. So this was a little bit more introductory, right? Because I don't know how many people have actually practiced Trataka. So there's like 3 stages of Trataka in Dr. K's guide, so y'all can check that out and really practice it. Once you learn the skill of Trataka, combine it with the Muladhara Yantra to target something like, that's what I would do for people who like have addictions, for example. So if you're like way too addicted to dopamine stuff, like this is a good practice. Okay? I think exclamation point guide. So the guide has a lot of other information. So it's like all the stuff that I was talking about, like we talk about the history of meditation, different kinds of meditation. There's a lot of stuff in there about meditation. Is there only, no, I think there's 3. There's external Trataka, internal Trataka, and Yantra Trataka. But external and internal, 2 of those may be in one video, but there's actually 3 discrete steps. So people are asking, how is it helpful with addiction? So the first thing to understand is that scientifically, this is also in the guide, but we'll give you a quick summary. So scientifically, we know that mindfulness practice or meditation practice is effective for addictions. The problem is that the science doesn't specify what kind of practice is good for what. So that's where, as a clinician, I make recommendations that are not grounded in scientific literature, but are rather grounded in the roots of meditation. So this is something that I know sounds kind of weird, but meditation was effective. So there's a group of people who've been saying meditation is effective for depression and anxiety, for example, or addictions, or personality disorders for like 5,000 years, right? They've been saying this for a while, and they made lots of other conclusions about meditation as well. So they said, hey, this stuff works. And furthermore, that specific kinds of meditations will cultivate certain kinds of energies and should help with certain kinds of problems. That's what they've been saying for a few thousand years. So about 50 years ago, modern medicine comes along, and for the first 100 years of modern medicine, they thought it was all BS. They're like, that's ridiculous. Meditation doesn't help anything, right? There's no scientific evidence for that. A couple of doctors and scientists learned how to meditate, and they're like, wow, this is making a profound change in my life. So then they decided to study it. So they were like personal converts before they studied it. And then they started to demonstrate scientific efficacy. So I think what's going to happen now is, like, over the next 20 or 30 years, hopefully, we'll start to study some of the other hypotheses that the meditative tradition offers. And one of these is that doing this weird tantric yantra stuff could help with particular faculties of the mind. So I don't know how it works. I mean, I have some hypotheses, but that's explained in the guide. Can't go into it because it's a whole lecture here. But so this is sort of like, because I know scientifically, like, it's a fair recommendation because it doesn't seem like particular things are more or less effective. So like you can sort of make a recommendation for any kind of mindfulness practice, and chances are it'll help. So it's sort of like an evidence-based recommendation in that part. What my hope is that there's an additional benefit based on the specificity of the chakra. And so based on kind of like the Eastern system, overcoming your base desires, which is what I think of as like the primary problem with addiction, involves cultivating Muladhara chakra energy. We want a medication on psychotropic medication sometime. I don't know what you mean by psychotropic. Do you mean like hallucinogenic? Because there are all kinds of things that are psychotropic medication, but I don't think that's what you're referring to. Like, psychotropic is just a term that's used for drugs that affect like behavior and thoughts. So, I mean, there's like courses on pharmacology. Like, if you really want to understand psychotropic medication, well, we could do a lecture on, different kinds of psychiatric medications. There's some of that stuff in Dr. K's guide too. Like, by the way, that's the reason we made it, because people have these questions all the time. And so we review, for example, different medications for depression and anxiety. And like raw, like high level, like here are the different classes of medications. Here's kind of how they work. Here's how you use them. But what usually, when I get that question, what I think people are talking about is psychedelics. And that too, you should check out YouTube, because we've got, we did an interview with Rick Doblin. So Rick Doblin is like the founder of MAPS. So the Multidisciplinary Association for Psychedelic Medicine. Y'all can also check out the interview we did with Will Siu, S-I-U. Will is a huge proponent of psychedelic use. He's also one of my colleagues from Mass General and Harvard Medical School, now out on the West Coast. He's also way more knowledgeable in this stuff than I am. And so check those out if that's what you guys are looking for. So like this is the challenge that we have at HG is we get all these questions in Twitch chat and like we've been doing this for like 2 years now. So we've answered most of this stuff. So check those out if that's what y'all are looking for. Is hydroxytryptophan a good alternative for SSRIs? I'd go ahead and say no. So in order for it to be a good alternative, I'd need to see data as to the efficacy of hydroxytryptophan. But I don't know that I've seen that. It doesn't mean it doesn't exist. I just may not be familiar with it. But I do think that some of the stuff about like Ayurvedic diet recommendations are essentially not necessarily the equivalent, but work on a similar mechanism of action as like taking hydroxytryptophan. So there are some, once again, check out the depression guide. So there's a lot of stuff in here about brain gut health. So this is scientifically based stuff. So like we know that altering your diet can alter your gut bacteria, and we know that altering your gut bacteria alters the production of neurotransmitter precursors, which in turn may alter the level of neurotransmitters within your brain. So for thousands of years, people have been treating mood disorders with dietary change in ancient India and China. And so what is the mechanism of action there? My guess is that the best scientific explanation is alteration through gut biome and therefore alteration of neurotransmitter production. But there are 4 discrete mechanisms of action that affect mental health when you change your gut bacteria, all explained in the guide. And I know this is starting to sound like an advertisement for the guide, but it's not an advertisement. Literally the reason we made it is because like we wanted to cover this stuff in a complete and like highly produced way. So it's like a 20-minute lecture with like visual aids and exercises and dietary lists and all that stuff, because we get these questions all the time. Someone else was asking, are we going to make more guides? The reason we made the guide is for all the common questions. So if there are more common questions, then we'll potentially make more guides. So this is just, and this comes down to like, what are we going to spend our time doing? Like y'all tell us, right? Because the guide was, I mean, it was a 6-month investment. So it's like, do you guys want me to stream more or this amount? Or like, would you rather have a guide or like more stream, right? It's like, which one? Just exclamation point guide. Okay, who are we rating, chat? Yeah, everyone wants everything. We get that, but I'm human and I have limits. We rated Arteezy last time. Let's rate someone else. Small streamer. So hopefully we'll get a couple of interviews. We've had such a backlog of stuff, right? So we just want to. Oh God. Okay, I have to. My hard drive is full. Chat. I can't even keep recording. Who are we rating? Someone else. Someone else. Code Miko. Katamina. Do you guys like Dota? I feel like we've got okay. Katamina, or it looks like she's not there. So small person or big person? Code Miko? Okay. If you guys want a small streamer, you got to give me a small streamer. Okay, we can rate ammunition. She's not exactly small, but she's awesome. So that works too. Okay. She's playing Minecraft. What? Okay, so I'm happy to raid whoever y'all want to. You guys just need to let me know with some degree of consistency. Okay, let's rate Anne, and then you guys give me a small one next time. I mean, she's not small, but she's only got 600 viewers right now. So let's send Anne some love. We'll see y'all on Friday. Take care.